All right, thank y'all so much for joining us. Today's training is over affirmative care. We have the lovely Dr. Salazar. You would like to introduce yourself?
I mean, they're going to hear me talk later, but Dr. Ana Salazar, my pronouns are she and hers. I'm a licensed professional counselor and board approved supervisor in the state of Texas. And I don't know, y'all will hear me talk later.
It's just a preview. And Miss Amy, if you would like to introduce yourself.
Hi, my name is Amy Nims. I use she, her pronouns. I am a licensed professional clinical counselor and supervisor in Ohio, and very excited to be here today.
Yes, we're excited to have you. Dr. I, would you like to introduce yourself?
Sure. Good morning, everybody. My name is Dr. James Ikonomopoulos. Most people call me Dr. I, and I'm the Tex-CHIP program coordinator. And just for you all who may not be familiar with Tex-CHIP, Tex-CHIP stands for the Texas Counselor Health Integration Project, and it's a grant-funded program by HRSA, the Health Resources Services and Administration. And Tex-CHIP is a program that's meant to strengthen the behavioral health workforce in Texas. And so we are training counseling students and other helping professionals, including like psychology students, to work in integrated behavioral health care settings. And so we provide trainings on special topics like anxiety disorders, depressive disorders, trauma. And so we're excited to have this training on affirmative care. So thank you all so much. And you can check out our Tex-CHIP website for a history of our trainings. Thank you.
All right. Make sure everyone is here. Okay, so see anyone else in the waiting room. Okay. So we'll go ahead and get started. That I've always talking. Yeah, help yourself. So we'll get started with our case study for our panel. So Alan is an 82-year-old white man who has identified as bisexual his entire life. He has been married for more than 55 years to the same woman, Patty. When the AIDS epidemic hit in the 1980s, he told Patty about his attraction to men. While they decided not to divorce for the sake of the children, they have two sons, they started sleeping in separate bedrooms. For the past 8 years, Alan lived with Patty, but has had a committed romantic and sexual relationship with Tim, a 69-year-old Black man. He has often contemplated sharing with their sons about his attraction to men and his relationship with Tim, but is afraid of being ostracized from his family, especially his sons. Because he has had to conceal his relationship with Tim, who he deeply cares about and wants to openly be with for many years, Alan often has struggles with his mental health. These struggles include trouble sleeping, but also struggling to get out of bed most days, isolating from his family and friends, and having frequent crying spells. Although Alan has had the same physician for many years, he is reluctant to share some of his more personal medical issues with him. When Alan shared even the basics about having sex with men and women in the past, the doctor told Alan his behavior put his wife at risk, which made Alan feel ashamed about his behavior. Recently, Patty was admitted to a long-term care facility due to a stroke that left her paralyzed and unable to communicate well. Alan also has medical problems. He has had severe arthritis and high blood pressure for several years now. About a year ago, Alan started having abdominal pain and noticed a tremendous loss of appetite. He waited for more than 6 months before going to the LGBTQIA plus community clinic again. The doctor there suggested that he go on his own or go to his own doctor for further testing. Although embarrassed to do so, he went to his own doctor and after testing found out that he had liver cancer. By that time, the disease had progressed and Alan went through surgery as well as chemotherapy. Now he needs more help and his doctor wants him to go into a long-term care facility. The doctor recommends that he go to the same facility as his wife and then they could share a room. Tim wants Alan to move in with him because Tim wants to take care of him. Alan does not want to share a room with his wife in that facility. The few times that Tim went with Alan to visit his wife, he noticed the lack of diversity at the nursing home and that the staff talked with him but avoided talking with Tim. However, if he moves in with Tim, Alan figures his sons will think that was weird and will want to know why he does not want to be with Patty. Neither of them had ever disclosed Alan's sexual orientation to their sons. Alan feels more and more hopeless every day. He doesn't want to lose Tim if he chooses to go to a nursing home. And he has not yet discussed his options with anyone other than his PCP and the LGBTQIA plus community clinic. The clinic recommended and referred Alan to meet with a therapist within the clinic's counseling department, to which his PCP also advised him to speak with a professional to assist him in navigating and exploring his potential options. So the first question for our panel is, what diagnosis or diagnoses would you give Alan? What symptoms support your diagnosis? Oh, you don't have to go first. I was just handing you
Oh,
the
you're
mic.
handing me the mic. Okay. Well, I mean, since I got it, I guess I'll go. Do you mind if I answer question 1 and 2 at the same time?
Yeah.
Because I would not assign a diagnosis first before meeting with him and doing assessments. So, and having worked with people who are trying to navigate medical care systems, he's 82. So he's gonna have to use his insurance. He probably have Medicare. So he's gonna need a diagnosis in order to get the stuff paid. So I don't mind using whatever the diagnoses the doctor already has on there, like the referring doctor, like the PCP or something. But I would still want to do further assessments before I even think about doing some things. It can feel really loaded, I think, sometimes. I didn't bring my cheater, so I'll have to like for assessments, provisionally, I don't know, adjustment disorder with depression, just to start, just to get something on paper. I would be very cautious about some of the formal assessments, like the BDI, the Beck Depression Inventory. Sure, lovely, great. And the way some of the questions are worded, like, I'm only gonna be 50. Yeah, I feel old. Yeah, I can't sleep. You know, so some of the stuff like future orientation is really loaded with a geriatric population. A lot of the questions, not a lot, there's like 3 or 4 questions in the BDI that are future oriented. And so that can be a little tricky, I think. I don't work with geriatric populations specifically, but there are a couple. The one that I knew off the top of my head was the geriatric depression scale. And that one feels a little better to kind of address some of the things. Again, if he's in the medical system, they've probably already done a PHQ-9. So I could follow up with another one of those. And definitely do a CSS, I always get it wrong. Columbia Suicide Severity Rate, CSSR. Y'all laughing at me, I got my glasses. I always get the acronym wrong, but the Columbia Suicide Severity Rating Scale, especially because suicide rates and risk are higher in elder white men. That's it.
Amy, do you have anything you want to share on this? Oh,
Sure.
questions?
Yeah, sure. So I agree with everything you said, Lena. I think that was that was great. So I would say, as I would definitely lean towards the geriatric depression scale, given his age and situation, because you're right on about the Beck. To me, having long-term, at least it seemed like having long-term crying spells, inability to get out of bed. I think we're pretty safe to give an adjustment with depression or depressive symptoms, but he really seems like he's got major depressive. And in fact, I would almost classify, not without talking to him, but I would almost classify him as moderate at this point because he's got a lot of life stuff happening, but it seems pretty severe to me. So I think comprehensive psychosocial at diagnostic is your key to kind of asking a lot of different questions to get some background on how long he's maybe had this depression, but he's got a lot of stuff going on. Yeah, so I agree with everything you said.
Hey, thank y'all. So what would implementing affirmative care treatment look like with Alan?
Go ahead, Amy.
Okay, sorry. I'm so sorry. You guys are very small on my screen, and I wonder if I can even change that. Um, that would probably be better. My eyes aren't great either. Um, okay. So I'm gonna look at my notes. Um, and now I want to go back to the other screen. Isn't that funny? Sorry, guys. I'm not used to doing presentations online. On Zoom anyway. So can you ask me the question one more time?
Yes, we're looking at question 3. What would
Okay.
implementing affirmative care treatment look like with Alan?
Yeah, so there's a lot going on here in this case study. There's a lot going on. Um, I really believe that for me as a clinician, I didn't give my background when I introduced myself, and I probably should have, so I apologize. I'm in private practice currently, but spent about 20 years in community mental health, working in systems, specifically as an LGBTQ clinical lead for the nonprofit that I worked at. So when I am kind of starting to tackle this, situation, obviously you want some major things in place. So I know it's subtle, but it's important. So do you wear a name tag? If you're wearing a name tag, do you have an affirmative symbol on your name tag? In the office setting that you're in, do you have rainbows or anything that says I'm an ally or we are a safe space? So there's a lot that you can do to your space to set up an environment for your patients to come into that can help feel very affirming, that can just kind of reassure them that, we're here together in this together. And I'm a safe person. Adding your pronouns behind your name, kind of like we do, is also another way to kind of show that you have some awareness in the community, that you have some awareness of people might have different genders, and that's okay with you. Um, Sorry, I'm trying to toggle between my screens here and it's not working very well. So I'm gonna actually do it on my phone. So I apologize if this looks rude, but I'm not on my phone. Um, Texting and hanging out with people. So you want to make sure your environment is absolutely demonstrating your beliefs and feelings as an ally, if you identify as an ally or an affirming space. Um, I think some of the wording, even in the case study, I noticed some of the wording is really important for us to question. For example, the information we were given that during the AIDS epidemic, he came out as bisexual. That's an interesting way to kind of like put that. I mean, rather than just showing it's 1980s. Um, I have lots of questions around that. Obviously, I'm not going to get into the weeds in a clinical assessment necessarily here because we're talking about how to start affirmingly. But part of having affirming care is your mindset. And so when you're a clinician and you're thinking about sexuality or gender, we really also have to decide that we are going to differentiate that from behavior. So just because he came out implying during the AIDS epidemic, like there was some risk, is kind of how I read that. Maybe I'm wrong, but I kind of read that as it seems like, this seemed like a risky time. So that's why he decided to come out to his spouse. Um, it kind of couples behavior with our orientation. And we want to make sure that we're not necessarily doing that. People can identify however they would like to, but behavior is very separate. So we want to make sure that we're not making assumptions because someone identifies in the LGBTQAI plus community, that we're not making assumptions that their behaviors are going to act in a certain way. So I'm trying to stay on task, you guys. I have a hard time with that. So I'm going back to my question here. Making sure that this affirmative treatment is what it's gonna look like. I think again, as someone, you have to show that you're affirmative with your environment. You have to show you're affirmative with your beliefs. I talk a lot about this with people that I supervise. It is really important if you are going to work with any population different from yourself or even like yourself, that you are doing your own self-reflection as a counselor and that you're identifying your own implicit bias. If not, it does come out. So, affirmative care means that you've taken a look at yourself as a therapist as well, and that you have actually decided, I'm going to look at some of the hangups I have. We all have them. Implicit bias is every single person, every single orientation, race, and everyone has them. We just need to know what ours are so that we can make sure we're not bringing that necessarily into the room and we're sometimes even challenging it if it's a stereotype or if it could be detrimental to someone. So setting up affirmative care has to be starting with, if you decide you're going to be someone who offers affirmative care to this population in particular, since we're talking about Pride stuff, this is our month, then we really want to make sure that we are challenging some of our beliefs before we decide to work with this population. I'll let you guys go ahead and take from there unless you would like me to keep talking, but that's a good start.
Thank you, Amy. Ditto. I'm actually wearing a pin today that says, "You are safe with me." So the first thing that I noted, and I agree with the language, and that's not a detriment or like a knock on whoever's writing it or wherever you got it from. That's just how people kind of categorize and what, you know, our community is faced with navigating systems. Some of it seems so negative, and I love me a lavender marriage. We don't know. I mean, they stay. Amy laughing at me. Good lavender marriage. I mean, it looks like I did a little timeline, you know, when I was highlighting this stuff. Hold up. I was like, okay, I did math. If he was born in 43, he married Patty in the 70s. His kids are Gen X. That's my age. They might be I.
I
But
did
there's a
the
lot of-
same thing.
Did
I did
you?
the same thing. I mapped the whole timeline to see where we were at. Yeah.
Yeah. And to find like a partner in your 70s, go off, dude. Bruh, I love that for him. And the family systems are so weird and navigating dynamics. And they slept in separate bedrooms, but by the 80s, 90s, she could have left him. Anyway, there's so much other stuff there that could be good and helpful. It just seems so negative, you know? And Tim wants to take care of him. So I think the biggest note that I made in bold was include Tim in the decision-making processes, right? Even if that's not his married partner, that's his chosen partner. And some of the benefits are already built in there. Like, he wants to move in with him. Does Tim have family? Does Tim family know he out? Like, does he know that he could take care of him too? And catching the vibes of this nursing facility. You want to talk to Tim? But Tim is going to the nursing facility with him to go see his wife? Girl, let me stop. So acknowledging all of that stuff, besides like having pride things and, you know, using pronouns and stuff. ¿Cómo se llama? What's his name? Alan. I forgot Alan's name. I'm so excited about Tim. You know, Alan has faced a lot of I'm stuck on my charm bracelet. That's what I get for talking mess. Alan has faced so much discrimination already. Even just the flavor of you're putting your wife at risk. And those things. Oh my gosh. Anyway, that's why I'm training it a little bit. There's a whole bunch of other things in there, but really primarily besides to follow what Amy said, it's just including Tim more. To find a partner that late in life and to not have them included. And you would, with this is heteronormative relationship, that Tim would be involved in all the care, right? Especially at this age. And personally, as a clinician, when I'm looking for keeping somebody alive, because I do a lot of work with suicide intervention and prevention and quality of life and stuff. Can we find some joy? What you got, 10, 20 years left? God willing? So that's it, let me stop.
I agree. With the finding joy is important, I believe. I think that, as clinicians, someone walks in the room, we have a lot of power in how we respond. And so when someone comes in and says, well, I'm married to a woman, but I've actually had this relationship with Tim for 8 years, our response is going to be very telling. And so if we're like, oh my gosh, tell me about that relationship. How did you guys meet? Get a little excited on his behalf and show him there is nothing to be ashamed about. And I'm going to hear the nitty gritty about how did that work if you're also married? Did you guys have an agreement? Was this all right? Like, tell me more. But we really want to make sure that we're checking our reactions and making sure that we can go in and say, not only I'm going to be neutral, but I'm also going to be maybe even a little bit excited for things that he says are positive in his life, like an 8-year relationship.
So how would you include other professionals as part of an integrative treatment team to treat Alan? Oh, she said, go ahead.
Yeah. Um, so first and foremost, I mean, this can get a little tricky and there's a lot of unknowns in the case study. So in working with Alan and talking with Alan, getting to know him, um, my first question always is, how do you want me to identify if I had to in a room with other professionals? Collaborating is amazing. So I'm sidebarring, sorry. Collaborating is the best thing in the world. You never have to be an island. And so the idea that I think a lot of times, especially I'm now in private practice, and you believe and think you're an island. If you're the mental health specialist, then you have to know all the things, and that's not the truth. Going out into the world as therapists, we actually need to remember that we have resources and consultation and we have a team behind us. And so really making sure that you talk to Alan about how beneficial it can be to make sure everyone is on the same page and make sure that we are all talking and using all of our heads in the room, is really important. And it takes some onus off of you as well. So I really appreciate collaboration. I really think teamwork, team treatment is actually the way to go. I always think more heads in the room is better, until we get to decision making, and then we'll talk it out a little bit more. But that always should be up to their client anyway. Okay, so I'm going to kind of emphasize with Alan a little bit about team care, and I'm going to talk to him about what are you comfortable with as far as inviting Tim into the room. What are labels and how do you and Tim refer to each other? Do we want to make sure that the team understands that if your sons are ever involved, that um, they don't know the history with Tim? As a therapist, like, upon working with Alan further, I would absolutely explore his sons not knowing and kind of challenge that a little bit, separate bedrooms, things like that. But understand that if truly by lots of digging into how his relationship with his sons are, why would it be weird? Is this real or imagined? Do they have beliefs that would support this belief that he could be ostracized by them? Or is this his own shame? And so there's a lot of digging there, but quickly getting started as a team is important to say, what labels are you comfortable with? Who knows what? What are we going to make sure as a team we all understand and make sure that we are respectful of, for you and for Tim and Patty? If Patty's involved in these conversations, which I'm not sure, given what's going on with her, she would be. Um, I'll pause there and let you go. I can just talk forever, so I got to cut myself off sometimes.
Same, but I think we're vibing, Amy, because my first little note here is ask him where the advocacy would be the most helpful. And I just echo all of that. You know, I have no problem as a therapist using whatever labels. If you want me to go in with the doctor and collaborate and advocate and say this is your best friend or something, or your, you know, friend like a brother, or whatever's gonna help, whatever's gonna work, right? And even just doing that, this sounds real bad, but here comes Dr. Salazar coming in to talk about Alan with, you know, the oncologist, and I'm gonna lean into that doctor title. I don't use it all the time. Y'all call me Dr. Anna, I don't care. But if I'm gonna go advocate and be like, well, as the professional, this is what we're gonna do, and this is what his best friend Tim is gonna be really involved. Those kinds of things. That's usually where I lean my weight, not anywhere else. Because that needs to happen, right? It looks like some power has been taken away from Alan over a lot of his different situations that he's been in, and anything that I can do to uplift him as a clinician, as an advocate, in a little advocacy way, right? These little things of standing up and standing for your clients and getting the care they need, especially with a complicated case. This case way complicated. I'm gonna need to be talking to all different kinds of peoples, like finding out who's a queer accepting, affirming attorney, like is there paperwork needs to happen now that Peggy, wife, Patty, they're not my clients, so I don't know their names. You know, her care and then his care and then financial stuff too. Again, I don't work with the geriatric population a whole bunch, especially not in assisted care facilities. Who's paying for what? Medicare gets so tricky and nasty. And you know, could they afford the both of them anyway? I don't know. There's a whole bunch of other systemic stuff that's going on here with the older generation. So leaning into and collaborating with all of those different partners and stuff. All of those pieces, right, are missing. And it's not just from a case study. I want y'all to know that sometimes you don't find these pieces out until after biopsychosocial, until after an intake, until after reading all the doctor's charts, until 5 sessions in. Oh crap, I didn't know about that part. Okay. You can't fix any, Amy laughing with me. You can't find any of these pieces out in a 50-minute BPS. Even if you have the luxury, like in my private practice, we schedule an hour and a half for a BPS, right? You still ain't gonna find that, all these pieces. So I think part of us providing affirmative care and, you know, including other professionals is knowing who the professionals are, right? Especially if you do tend to work more with certain populations, whether it's elder LGBTQ folks or youth. Who are your touch points? Like here locally, do y'all even know who Orlando is over at the Pride Center? Do you know who these people are? You know, just all of those pieces and elder generation. I don't know. There's a bar, but you know, you need to find out who those people are so that you can, because there's different kinds of professionals, not just the medical and the mental health professional side. Let me stop.
And I love what you said, Anna. I think that you needing to know your resources in your community if you're going to practice in this way. And additionally, if you don't, so let's say there's an oncologist specialist that you know, you're not going to know everyone, but you set the tone. So again, going in and making sure we're talking about things in a very normal way, which sometimes people struggle with. And so I don't want to just pass that over, saying things like, yeah, no problem. This is what's going on. This is fine. This is great. And normalizing it in front of other professionals is a way to really set the tone as well. Like, I'm going to give my pronouns. I am going to talk about sex. I'm going to talk about sexuality. You know, like these things we don't balk at as therapists and we don't think they're weird. And so we want to make sure that we're demonstrating that and modeling it as well.
Yeah, and that leads perfectly into question 5. We kind of slightly touched on it, but what resources might be helpful for Alan?
Yeah. So again, I'm in Ohio. You guys are clearly not. You're in Texas. I'm actually literally in Washington State right now. I'm on vacation. So it's important to know your resources. And truly, there are some national resources that are fantastic that can get you pointed in a more specific way for the community that you're working with, such as the age range. Like SAGE is a great population or a great resource for our elderly population that identify in the LGBTQAI community. HRC is a national organization. It's Human Rights Campaign. If you've seen the blue stickers with the yellow equal sign, that's HRC. HRC does a ton of advocacy on every level. They truly are an all-encompassing, a very all-encompassing, they're not the only, and they have been given feedback to become more diverse. And so they have tried to embrace that in the last 10 years. But they're a great jumping off point and can give you studies and articles that prove what affirming care is for these specific populations. So I love that they also come from an academic standpoint in a lot of ways. So there are resources out there. Knowing your local resources are really going to be important. Dr. Anna, I'm going to let you kind of go with that because it sounds like you have the beat.
There's not much beats here.
Oh.
But that's all right. That's all right.
Yeah.
Yeah, locally, we do have a couple of things. I think medically, the LGBTQ center that Alan would be attending is going to be the Coastal Bend Wellness Foundation. They originally started in the 80s and 90s, early 90s, I think was the real date, as Corpus Christi AIDS Foundation, right? And so that's how they got their start. And then they've got some amazing grant writers and they got some good monies in. And so now it is this over the decades. Boy, I feel old. Over the decades, it is now a low cost, accessible wellness hub. So there's all different kinds of programs, all different kinds of sub grants and things that they have in their facility. So primarily it is a medical clinic, a community medical clinic, but there's so many different little behavioral health pockets. And that's probably who he was talking to, was one of these doctors over there for medical care. They have the Pride Center built into that facility, our Corpus Christi Pride Center. I actually am gonna lie because I don't wanna lie. There's always so many different programs and grants that I can't keep up with what funding stream is available for what population. There's very, very consistently medical care, even pharmacy, like they'll deliver your meds to you. So that might be helpful for Alan, who might be struggling sometimes. Does he have to get all his meds from these other places who are not safe when they can just deliver them to his house? Right? That's the kind of facility that we have here also, where if he took Tim with him, it would be fine. Right. Locally, we also have a couple of churches. Now, there's nothing mentioned about faith or spirituality with Alan in particular, but there are a couple of faith organizations. I work with Reverend Dana. There's like St. Paul's, and there's the Universal Unitarian, UUC, over off of Holly locally, on the Corpus Christi Pride Board. So there's a nonprofit organization called Mosaic Project, and housed underneath that is Pride Corpus Christi, and that is separate from Coastal Bend Wellness Foundation. And they have a website with all of their different initiatives and resources and stuff. And I collaborate with them a lot. They're the ones who fund and assist the transgender support groups that I offer for free at my clinic. If I don't know something, I'm just texting the president, yo, where is that thing? I need an oncologist who is friendly. I need transport help to San Antonio or Austin or MD Anderson, to help take care of Alan. If I don't know, I'm going to find somebody who does know.
I love that. You are not an island,
No.
right? Yeah.
Can't be an island.
Right.
Because people are not islands.
Right.
Individuals. So why, as a clinician, would I expect myself to be an island when I'm still a whole person too, right? And I'm working with individuals who have their own systems and their own areas of life they're trying to navigate. This month is Pride Month, right? So there's all kinds of different The Pride Board this year has really focused on expanding and not just like fun drag brunches. I mean, I love my queens, I love my kings. And there's an arcade night where the kids can go at a local friendly spot, things like that. So this is actually a great time of year to find all of those resources, bookmark them. It's gonna be all over Facebook, lots of events, lots of things, bookmark all the little spaces that you know what to come back to keep in your little pocket of knowledge and resources and stuff, because if you don't work at Coastal Bend Wellness Foundation, or if you don't work at my center that works with a lot of LGBTQIA folks, and you just work anywhere in the world, someone gonna come through and need some resources. Someone gonna have an identity one day. They're gonna check that little box, and you're gonna have to ask, and you may need to find them. So just because you might have to be here because it's Tex-CHIP and this is not your chosen population, for whatever reason, right? You want to specialize in different other things, and maybe whatever. I don't know. I don't care. You still work with people, and you might need it one day. So, and HRC is getting better. Trevor Project online. Not only do they have the Trevor hotline for text and call for youth who are experiencing suicidal thoughts that are part of the LGBTQ community, but they also have a lot of articles and research and data. ¿Qué más? HRC, yes. Yeah, those are some good starts.
I also like that you mentioned that, we don't know if he has a faith connection, but we really, depending on the community, we really need to find connections wherever we can. What we know is that one affirming, accepting person can lower our suicide rates and attempt rates in the LGBTQAI community by 40%. So one person. So one organization. I mean, think of the messages that you're given if you identify in this population, and there are laws against what's going, you, or against what you hope to do in your life or whatever. There's a lot of implicit messages that you're getting in your community. So one affirming organization, church, group can actually really change your trajectory. It's important to know that.
And so what tips and suggestions do you have for novice professionals to be mindful of when treating clients who identify as LGBTQIA+, and providing affirmative care in today's political climate? What are some cultural considerations for treatment regarding Alan?
There are a lot. So we've kind of touched upon a lot of this, but I mean, everyone, again, I would encourage you, if you decided you're going to work within a specific population, understanding intersectionality of identities is extremely important, and doing some work to understand those crossroads, for lack of a excuse the pun, but the intersectionality of different identities is going to be extremely important to understand. So Alan specifically, we have white, male, older, which makes a difference because some of your terminology that you're going to use, you might not use the word homosexual, because as someone who's an older man, that was a very pathologized word in the 70s. And until the DSM decided to take it out, that it was not a clinical mental health disorder, homosexuality, it was extremely pathologized. And even then it was still. So I know many of the baby boomer generation are going to say, call me gay, call me bisexual. Don't use the word homosexual because it's extremely pathologized. So like little nuances like that. And again, guys, you don't have to know everything. You have to know how to say, oh my gosh, I'm sorry. Tell me what you would like for me to call you. You tell me how to address things. So we have, there's a level of humility when you're a therapist, right? And you have to be able to say, yep, my bad, I'm sorry, and move on. But allowing them to teach us, what is most important for them.
yeah, we can't know everything, so I echo that too. I learn new, especially the kiddos, I learn new things every time I get a new kiddo. What is that? Um, but what did I write down? Be present, be visible, don't judge, and take your time.
Perfect.
I also wrote that different generations have different approaches and receptiveness. So exactly. I mean, even queer, right?
Yeah.
I mean, there's some history with kind of taking that word back, and that's like a socio political justice stance of reclaiming the word and the identity. And he boomer. So that was a very, very derogative term for a long time. What else did I put? Oh, and also boundaries and rule settings, regardless of what orientation is, right? Because boundaries look and feel a little different with each flavor of theory you're using. But that looks different with older generations, you know, than what a younger clinician. What?
I said they don't have any.
They don't have it.
Older generation.
Well, so they have rule setting though.
Yes.
And so there's these rules and boundaries he's created within himself of what he's not going to feel comfortable with sharing with his family. And like, you know, some other things. It feels different. It's different flavor. Um, so just be present and be visible and don't judge, especially in this political climate. Everybody's fears and realities, everybody's fears are based in realities, right? This is not some ominous, I'm scared of whales kind of thing. I have a client who, back in the day, who was like terrified of whales. And I was like, you're never gonna see a whale. Okay. You're landlocked. I don't, okay. I mean, cool. Right. There's not, it's not, and that's just a phobia. That's whatever. But these are not like weird things to be scared of. These are very, very present realities, just like our Latinidad community right now. You know, there's very, very real potential fears, right? And so not feeling safe doesn't mean you automatically have GAD and that you're nervous and anxious all the time. So be very present and be very patient. Anyway, I'm gonna stop there too.
So what personal examples can you share regarding providing affirmative care in an integrated treatment setting or just in general?
Yeah, I really thought about this one a bit. I feel like, so my background is working with um, youth in residential facilities as well as in their families and things like that. That's where I kind of started my career. And it's pretty interesting. I've been doing it for a long time, so I have seen a change in how we treat our LGBTQAI population, which is good in a positive way. But we really also just need to give people space for where they're at. I'll give you a few examples that might help illustrate this a little better. In the residential facility that I was collaborating with, we had child specialists who were uncomfortable with LGBTQAI folks in the population and thought that they were doing the best thing by saying, you have two moms and I don't want to hear about your family. You need to talk to someone else. And referring them to someone saying, oh, I'm not comfortable, so I'm going to just tell them not to talk to me about it. And so we have to educate around that and say that's not okay. Because that also spurs shame and that, there's a lot of things that maybe you didn't intend to do with those comments, but that was a real situation that we had to talk about with one of our two actually of our mental health specialists that were working on the unit who believed that they were doing the right thing, I think, by saying this doesn't align with my religious background. Specifically, they were saying their religious background, this did not align. So they said, I can't say anything nice, so I'm going to tell them, don't talk to me about it. I understand that to some extent, and in a professional setting, that you have agreed to work with all types of people. You have to be able to check your bias. Again, we talked a little bit about implicit bias earlier. Check your bias and make sure that, we're not doing more harm, right? I've had people in my training say, well, what's the difference? Why do we have Pride and Pride Month and we don't have straight pride? Or how can I support the kids who are uncomfortable on the unit with LGBTQ kids? Like, I mean, we're supporting the LGBTQ kids, but there are kids that don't want to be around them, and I want to support them. And I say, okay, so I hear you. And we don't promote discrimination of any form. And so we want to make sure everyone has an equal, kind of say in who they are. Historically, populations without the power, populations that are oppressed, do not have the same access to resources and treatment that the majority population has, such as the straight population. So until we can actually start speaking equally, we feel like there needs to be some representation for these oppressed populations. And you can say that's the Black Lives Matter movement, that's Pride, that's any population that is not the majority. Bringing awareness to, the resource deficit or the actual, in some cases, violence that is inflicted upon the population is important. So again, saying one population needs to be highlighted is not taking away from the majority other population. What it's doing is highlighting the lack of resources or the violence that has been inflicted on that population. And that doesn't necessarily mean not to get too in the weeds here, but that doesn't necessarily mean that this is a fault of one other community that is oppressing. It is across our board. It is what happens with societies. The majority people tend to be the loudest because there's the most majority, right? So it's not meant necessarily in maliciousness. It is what has happened because we haven't checked our internal biases. So our systems are internally racist or homophobic because they're, just there hasn't been enough integration of all the people in our culture. So while, we have 10% is kind of the idea we think 10% of our culture is LGBTQAI in some capacity, which is a number that we can't really prove because we weren't measuring it for a very, very long time. And now that the definitions have expanded to incorporate a lot of other things. Anyway, so we don't see 10% though representation in media, in our boardrooms, in our, surgery centers and things like that have equal representation of those folks kind of across the board. When there isn't that, then we want to make sure that we are highlighting it at certain times with Pride Month and Black History Month and Women's International, history and things like that. So really making sure we understand a bit about privilege and a bit about our own implicit biases is going to be important during this. I've talked too much already again, so I'm going to let you. I have more examples of you. I mean, there's a lot of times people, have questioned, and again, not necessarily from a malicious place. So just wanting understanding, and I think it's really important for us as mental health specialists to be able to set up a non-judgmental space for people to ask questions and people to talk about like, why do we have Pride Month? Why do we, celebrate these people? I don't understand. And so great, let's talk about it.
You didn't talk too much. I could listen to you talk for hours.
Thanks.
What personal examples can I share? Y'all, I have too many.
Right.
But I will say that I think, well, when I first started doing clinical work, it was like 2012. So it's like a minute ago. Before we had the MSJCC, before we even had an ethics class designated in our counseling programs, right? That's like a, Elena went. Right, it was a different looking curricula. When I graduated, I went to go work in community mental health. And we were obviously still using the DSM-4. Huh?
Said, oh, Lord.
Girl, tell you. You know, and when I left that facility in 2016, they were still using DSM-4, even though DSM-5 came out in 2014, that first version, 2013. Thank you, Dr. I. Yeah, they were still using the DSM-4 because it cost too much money to update the system. And I don't know if Dr. I, if you were still at MHID in and out that point, it was driving me crazy. Yeah, crazy. I said crazy, it was driving me crazy. Just to have to use a multi-axial system, y'all don't know nothing about all that. All of these negative terms and things, and so just there was no space to really be more affirmative because you had to use the DSM-4 axial criteria, and you had to put these diagnoses and do these things this way. And globals, anyway, all this other stuff that thank goodness we moved past the GAF and all that. Because my GAF be low. Y'all don't know what that means. Dr. I does. So there was not a lot of room, especially in those community care systems. So they had to be very, very micro affirming steps of, you know, oh, that's your partner. Oh, you have a wife. Oh, you have 2 moms. Oh, you have 2 dads. Just those little tiny things that you could do, I think really helped in that community setting that I worked in. And just a lot of confusion from older clinicians. Again, that was in 2012, 2013 or so. So they'd already been in the field for a minute, 20, 30 years. Like, what do you mean they got 2 wives? I'm like, oh, boo. They're lesbians. Dang.
I can't tell you, I literally got called down to our residential facility at one point, and a teenager was in trouble. You think this is 2007. She was in trouble, and she was, being separated from her tribe is what we called them, and from the other kids. And I said, okay, they're like, Amy, you need to get down here. You need to come talk to us. It's like, okay, so what happened? Thinking something, I mean, like these kids were violent and these kids were thinking something really crazy happened. And they were like, well, she was in the cafeteria and she called herself a lesbian. And I was like, no, well, that's okay. So we allow self-labeling. And, we have come a long way, which is really great to say. But it was a different playing field. And I also got called to one of the tribes because I was running an LGBTQAI affirming group at the time. And one of the kiddos was calling everyone homophobic in his tribe because he was in my group and he said, everyone is being very homophobic in this house. And I said, okay, so what's going on, kiddo? Like, what are why do you think that? He's like, well, when I smack other butts, they get really upset. And I mean, I'm allowed to smack boys' butts because I'm gay. And I said, nope. So that was the other way. It was like, nope, nope. Personal space boundaries. That's no, we're not touching other people. No. And that doesn't make someone homophobic. What that does is say they have good boundaries. They don't want you touching them. So there's been learning all the way around in the years. But sorry, Dr. Anna, not to cut you off.
That's okay. Mine are boring.
Well, that is the end of our panel. Thank you so much to Dr. Salazar and Miss Amy for sharing your insight. Students, do you have any questions for them? No. What about our peeps online? Do y'all have any questions? Oh, we lost some. Oh. We have one. Okay. Nick, okay, we do have a question.
So you mentioned with affirmative care that you want to have like symbology or a display that you're a safe environment, a safe person. And sometimes you run into people that are very uncomfortable with that. So how do you strike the balance so that all people feel comfortable in the environment in a way that might even open up the opportunity to dispel some stereotypes that exist?
I don't know if Amy, your question.
Did you hear him? Oh, I didn't even think of that. Did I grab the mic?
Here. So the question was, how do you create an affirming space for communities while also making it a comfortable space for those who may be uncomfortable with an affirming space? As a clinician, I'm an advocate. As an educator, I'm an advocate. And so I'm gonna put it up. Also, my specialty is working with historically and intentionally excluded marginalized populations. So I'm gonna put it up. And I just have the conversation with the person. It looks like you're feeling a little uncomfortable. Is it my vibe? Is it the room's vibe? And if they tell me straight up, okay, well. Okay. And I just acknowledge that that's the feeling that they're having. If they choose not to come back to me, that's fine. That is what I do. Also, I'm very privileged in that I own a private practice. So if they don't want to come see me, they don't have to. However, when I did work here at the university as the associate director for the counseling center here, literally, I would have to see everybody. And I just hold space for that person the same way that I would hold with anybody else. So literally the day after both elections, 2016 and 2020, I left before 2024. I was the crisis walk-in person. So I had people from both parties, both sides coming in to share. Yeah, they were long days. So 10, 12, 14 people. And then the whole week after that. And you just sit and hold space with them the same way that you would with anybody else. And sometimes working with somebody is just like, I just need to get this out and, oh yeah, I see that flag. I don't like that. You have a Mexico flag in here too. I don't vibe with that. And I'm just like, okay, well, heard, I acknowledge that. And is that the issue that you want to talk about today? Or are you talking about whatever else happened?
I love that.
Right, like we can spend your session talking about that. Or do you want to finish working on the grief and the anxiety stuff that you come in for? That's how I do it.
I also think I agree with absolutely everything you said. I think that, like we talked about, HRC has the blue sticker with the equal sign. Often people of the LGBTQAI community would know what that might mean, and other people who are not tapped into that community might not know what that means. So you can come up with some safer things if you need to. I would challenge that a little bit, I think, if you need to, kind of like what Dr. Anna said, but I think there's a time and a place for that. The other part too is, don't forget, as the clinician in the room, those representations in your office can be there or be important, but your words and your reactions are more important than anything. Not, a male walks into the room and you say, oh, do you have a girlfriend? No, you say, are you dating anyone? We're really going to watch our language to be affirmative. We're really going to make sure that we're feeling inclusive in our environment. So you're really setting that tone. And again, those subtleties often aren't picked up by people who aren't thinking in that term. So someone who might be offended by pride or by LGBTQAI stuff, when you say, are you dating someone, they're not going to automatically usually go towards, wait, are you trying to be affirming? Oh my gosh. So really making sure that we are also, if we're working with this population, using affirmative language and body posture and, reactions and celebrating things with those folks that are in the room with us.
Any other questions?
Yes. Like, where would you get all these resources? Cause like, I don't know where any of the resources is.
The question was, where would you get these other resources?
Yeah, sure. So again, we kind of talked a little bit about like, so for older LGBTQAI population, there's SAGE, and they have a lot of resources on their websites. HRC is a good place. Again, we kind of highlighted that they've been given some feedback to be more inclusive with intersectionality of identities, but they've done some good work on that. So HRC is a good jumping off place. There's the LGBTQAI task force that is a reputable, again, great place to start. There's Glisten, which is kind of media-based advocacy. There's lots of different things, but again, truly, if you go to one like HRC, they're going to have lists for you if you need that. And they actually will go down to a state level as well, and maybe even local, to be honest with you. I haven't been on there for a minute, but LGBTQ task force. I don't know if I can't see your board there, but yeah, there's quite a few actually. But again, starting with something that's pretty national, like the HRC group, can really springboard, you know, to other places pretty easily.
Just to confirm, glisten is spelled like listen with the G.
No, it is GLSEN. It's an acronym.
GLES.
Nope, GLSEN.
LSEN. I knew it was something.
I can, if it would be helpful, I can send over a list of kind of national resources to you guys. I can send a cheat sheet over so like when you get on the HRC website, they will, I mean, like you can literally contact them and say, hey, send me, I mean, they have everything, guys. So if you want to start a GSA, which is a gay straight alliance, like in a school system, send me a starter
We
packet.
have one.
Okay, great. So send me a starter packet and they'll send you brochures, they'll send you flyers, they'll send you stickers, they send you everything. They send you ally stickers for your offices and things like that. It's the same if you wanted like ally stickers or like I said, the blue sticker for your office or things like that. They will send you all sorts of good stuff so that you can actually put up in your office if you needed to or wanted to. But again, there are also academic articles and research on there that's really helpful too. But it's a great springboard platform to kind of find other resources.
Okay, well, thank y'all so much. We are going to go into our break. We'll take about 10 minutes.
Yeah.
Yeah, we'll take about 10 minutes, for students, like use the restroom, grab some snacks, whatever you need to do to take care of yourself. Thank you so much, Miss Amy
Yeah,
and Dr.
thanks for having me.
Salazar. Thank you, we appreciate you.
Bye, guys.
Just take as many snacks as you can.
So it is 10:05. We'll come back together at 10:15.
Testing mic. Can somebody tell me if it works online? Put a little thumbs up or something. Put it on.
Should be good. It's on.
Well, I'm just gonna keep going then. Really? Yummy. Are we ready? All right, good morning, everybody. In case y'all missed it, I'm Dr. Ana Salazar. My pronouns are she and hers. And I have been invited here to talk about affirming care in the LGBTQIA+ community. Thank you, Myra. So let me just go. Let's go. I know, Canva, I gotta press the thingies. Okay, how do I hide you? You're that? Another word. So we do have some objectives that we're gonna go over. These are objectives here. We're gonna talk about definitions and stuff. We're gonna talk about treatment, and then we're gonna look at some barriers and challenges. Typically, when I present, I have two different rules that I use. I use these two all the time. The parking lot rule of moving forward. I've gotten a specific allotted amount of time, and sometimes if we go off track, I may say, let's put that in the parking lot. That's not to discount what you're saying, that's not to dismiss what you're saying, it's that I only got a certain amount of time. So we can put that in the parking lot, we can circle back around to it if there's time at the end, or jot it down or something, and we can circle back when there's time. for questions at the end. The other one is, it depends. Is everybody in here a student? Well, except for Dr. Wright. Everybody's a student in some form or capacity. Everybody online is a student, I believe.
There you go.
Y'all don't like this, it depends.
No.
I know, and that's why I put it up here. This is a tip for presentations, is that it depends. I'm not gonna have all the answers. We're working with people, we're not building teapots. Everything's not the same. So sometimes I might say, it depends. And again, that's not to dismiss your question or the situation you're talking about, it's because it depends. What I've added here specifically for today's presentation is safety first. I'm going to talk about my identities, my experiences, and when we do share in this space, we can't assume that it's a safe space just because all of you are here. Y'all have to come for Tex-CHIP. So safety first. You don't need to share your identities or your experiences if you don't want to. I'm calling this the rule of privilege, where I'm a whole doctor, have a whole private practice. I'm already in the field, so I'm gonna talk about me. You don't have to. Okay, those are my 3 tips for today. I don't think I know y'all. These are new people. Like, I've seen y'all maybe like once or twice. I've done a guest or a lecture or something, but I don't know y'all, so I'm glad I added this one. So these are some pictures of me. This is the part that makes me uncomfortable, actually, is the stuff that I do. I focus a lot of stuff on research, education, community leadership, and uplifting professionals. Oh, some disclosures. I am being compensated for this, but everything that I say is going to be my opinion, my experience, my research. It is not reflective of Texas A&M University Corpus Christi or the counseling and educational program. Okay. So some of this, these are just some examples of some of the things that I do in the community. I win awards and stuff. This is a YWCA Careers Women thingy. I love to show up to hooding. It's my favorite day of the year. Literally every semester, I'm like, I get to hood somebody. And I do a lot of presentations. I'm also president right now of the Gold Coast Counseling Association. My term ends in a couple of weeks, but I'll still be involved in stuff. This is me at TCA. This is me with some colleagues in the community trying to create some safe spaces. And I'm also an Islander. So I graduated from here with my PhD in May of 2023. But besides that, I do a lot of different advocacy work. I have 3 main areas that I focus my advocacy work in, is the Latino community, suicide intervention, and the LGBTQIA+ community. So these are just some examples of things that I've done in the community. This is an old picture from coming out day a year or 2 ago when I was still working here. Pride Parade, suicide intervention walk, the gala, Vestido de Rojo, the red dress for American Heart Foundation. March for Equality was pretty recently. And then my practice also offers free support groups for transgender community. So this is some of the stuff that I do. And so I feel very honored and excited that I was invited to come teach and train y'all today, because this is one of the 3 things that I really focus my advocacy work on. We're gonna jump in. History can be harmful. We have to talk about history if we're going to talk about the work that we're doing for affirmative care and being inclusive. So there are some things that may contain hurtful information, because we're going to talk about the DSM and stuff like that. So take a break if you need to step out. I'm not going to be offended. Breathe. I know when I was writing these things, I didn't want to crash out. So if I'm the expert and I'm trying not to crash out, if you see something, it's okay to take a break. So why are we here? I pulled some data just to kind of start us off with. The two main sources that I got some of this data from is the Trevor Project, which does a lot of work with LGBTQIA youth, and they define youth as 13 to 23, 24. And then Mental Health America, kind of looking at overall general population. Like Amy was saying in the panel group, we didn't start collecting a lot of this data until the last few years. Maybe the past 10 years or so, we really started getting a lot of good data. But for the most recent stuff of individual youth who identify somewhere within the LGBTQIA+ community, 39% are contemplating suicide. And of those individuals, 46% who are trans or non-binary seriously contemplating suicide. And overall for adults, Mental Health America covers all ages. I think they stop at like geriatric age. But 48% of adults who identify as transgender, and then compared to the overall US population, only 4%. This is still a lot. I still don't like this 4%. And there's a big discrepancy and a higher rate of thoughts of suicide among the LGBTQIA community from both youth and adults. When I looked at some of the Trevor Project data, a lot of kiddos want mental health care, right? But 50% of them don't get it. And these are some of the reasons for not getting it. I was afraid I wouldn't be taken seriously. I did not feel they would understand my sexual orientation or gender identity. And I had bad experiences before, and I don't want to repeat that. And I can say anecdotally, one of my subspecialties when working with, I didn't tell y'all what I do for counseling. Yeah, I'm a therapist, group private practice owner. My specialty outside of advocacy work that I do is that I work with other clinicians. So my clients are mostly therapists, nurses, healers, things of that nature. And I also specialize in working with individuals who have had prior negative counseling experiences and are scared to go back to therapy. And so I hear this one a lot. I don't want to repeat. There's a lot of extra healing, a lot of extra work that goes on before you can get to the stuff that they're coming into counseling for. These groups of individuals. If I didn't say it, I probably didn't. Raise your hand, you have a question, shout out, go ahead.
So could you admit Anna?
Oh, no, Anna, you can't come in. My bad. Okay. If you can just keep an eye on
Yeah, sure, I will.
Okay, if I didn't say it before, pop off a question, raise a hand. If I do a parking lot too, that's for those reasons. Let me recenter. Okay. I don't like that type of thinking. So why else are we here? So there is a systemic and cultural impact on the LGBTQIA+ community. There are things like having limited support structures. There's some internalization of negative stereotypes. There's stigma. These bubbles are not indicative of any kind of data sorting or anything. It was a cute graphic. But these are just some of the things that we're seeing as a reality, right? Working with the LGBTQIA+ community, specifically with mental health. We're also here because we need some good peoples working in Texas because we need help. Texas ranks 51st as far as least accessible insurance with mental health care. So if you have insurance, you may not have access to mental health care within that insurance. We rank dead last. It's 51 because it's the 50 states and then DC. And we rank 44th because we have higher rates of mental illness and lower access to care overall. This is not just indicative of the LGBTQIA+ services. This is just overall. So part of the thing that I do as uplifting professionals is to make sure that there is good training, that there is good information, because if we want y'all in the field, we need more because we don't have enough providers. This is not exactly to scale because Canva only let me put 100 little peoples in the infographic. But nationally, it's about 341 providers for 341 persons for every one provider. And in Texas, the shortage is much more real in that 691 people to every one provider. And this is all providers, all mental health providers, psychiatrists, psychologists, counselors, social workers, NPs, all of that stuff. On top of that, compounding it, Texas has a lot of rural, I don't like that word, a lot of rural areas. And so Corpus is like, I kind of frame it like a little big city or a big little city. Because we're so kind of isolated, it's 2 or 3 hours to the nearest anywhere.
Big town.
I'm sorry?
Big town.
Big town. Yeah. So that can it could increase some of these things. When I used to work at the MHID, I used to run the clinic for MHID in Robstown. I was the only clinician for like 20-mile radius. It's like 20 miles to Robstown. It seems like right there, right? But that's wild. So we need you in the field. Yay. Okay, we're gonna switch gears to our first real objective and talk about terminology. There's a bunch of different ways we can talk about the LGBTQIA+ community. It kind of depends. Already with it depends. It kind of depends. Some people say to LGBTQ+, the two is for two-spirit. Some people say LGBTQIA+, some people say just LGBT or LGBT+. There is no one-size-fits-all acronym. No alphabet soup is gonna work for everybody. It depends in general. However, I'm not gonna use SAGES, but they have a really, really good, SAGES, what Amy was talking about earlier, is a division of ACA. And it's Society for Sexual, Affectional, Intersex, and Gender Expansive Identities. This is their graphic here of how they use their acronym. LGBTQIA+. Yeah, lesbian, gay, bisexual, trans, transgender, two-spirit, gender expansive, queer questioning, that's 2 Q's in 1, intersex, agender, aromantic, and/or asexual is the A, P is pansexual, polyrelationship, polygender, and then the plus is because things are ever evolving and ever changing. For brevity, and because a lot of the data uses this acronym, I'm going to be using LGBTQIA+ in the writing wherever I did. If I messed up, my bad. But this is generally what I tend to use because this is what's reflective in most current research, is this acronym here. Yes.
Is there, so I know that you said there's no abbreviation that's perfect, but is it offensive to not, like the one that you use, is there one that's considered more offensive than others? Like to not include, like, you know what I'm saying?
Maybe.
Shit.
It's
Sorry.
This is why I tend to go with this one, because it's got a couple of extra. We'll often see LGBTQ+. It can be offensive to some groups, to answer your question, to have the plus. Some people prefer to just hear LGBT or LGBTQ versus the plus, because this feels diminishing. It feels like, oh, if I'm not in this, like if I'm not in this group and I'm in here, that means I don't count. You have to ask. Part of how you identify. And it depends on which research or which center you're working in. If you're gonna work with Indigenous communities, you will see the 2 first versus starting off with a letter, because two-spirit is more reflective of their experiences and their identities. So you have to ask. Oh, that's the microphone. So even if we can't have a perfect understanding of which acronym we're going to use, we can understand some basic words. So I was really torn back and forth on how much like LGBTQ 101 stuff I should say, but since all of y'all are students, I'm glad I did a big overview approach. This is the gender unicorn. They're cute, I like them. But they also have a really good way of expressing what the different identity components are. So the gender identity is how you think about yourself internally, like how you identify. Gender expression is what you show on the outside. Your sex assigned at birth is your cisgender, like your, not your cisgender, what you were born with. Who you're physically attracted to and who you're emotionally attracted to. I did add a romantic attraction, because for some people that's different. If you want to know more, take you a safe zone training at the Coastal Bend Pride Center. They offer it several times a year. I know CSI has done it a couple of years ago. But Orlando does a wonderful job of explaining these and walking through a whole bunch of these things. The community is not a monolith. Just because it's Pride doesn't mean there's a whole different history and component for each identity. No one can be lumped together. Just like the Latino community, or the Black community, or the Indigenous community, it can't all be lumped together. It does a disservice to the individual you're working with. It can be helpful to understand care from this approach under this umbrella, but to assume and to just say, oh, you're LGBT, so all the things fit, does a disservice to their own individual identity experiences. Especially because, you know, the first Pride was a riot. Literally. Some of the first Pride events were protests. There's a lot of political movements within the LGBTQ community. Even when you consider things like the history of the flags. In World War II, Jews who were interred had the Star of David. Anybody who was gay or lesbian were identified with the upside down triangle. And there were some movements. Oh yeah. So there was some taking back of the triangle in the early, 1960s. Boy, I guess I put 1900s in front of stuff. And like the 1960s and 70s to take that back as an identifier. And then the first Pride flag that was commissioned by Harvey Milk included pink in it. And if you think this is just a cute flag, I didn't have time or space. This isn't a history class. But each color for each flag means something different. There's a reason why there's the stripes here and the stripes here, and these stripes all have different colors. There's a lot of depth in history and nuance. Even why we say LGBT, because it used to be GLBT. Yeah, it used to be gay, lesbian, bisexual, and transgender. But during the AIDS crisis, when men were ostracized, gay men who had AIDS and who were dying, lesbians stepped up. Okay. They said, we're not gonna let them die alone. And they took care of them. And to honor that movement and that sacrifice, it was changed to LGBT. There's history here besides just, this is my identity. This is who I am. Not everybody in the LGBTQ community is going to know all of this history. And a lot of this is triggering for a lot of people to know and to go through. So we might not know, right? And we definitely ain't taught this in school. We also should understand that there are differences within the community as far as like, even the flags you see. These are the sexual orientation flags versus gender identity flags. Remember, there are two different things on the unicorn. But even you can have more than one flag. You can be gay and genderqueer. You can be a lesbian and transgender. You can be bisexual and non-binary. Like, it depends. There's also some differences in how individuals are portrayed and how we perceive them through social media representation. Laverne Cox is lovely, but she is different than RuPaul. But people be lumping them together. It's a whole thing. That's a whole different training. But as long as we understand those and that we can approach those with humility and acceptance of understanding, and that we may need to learn more, generally we're all right. We can get there. Questions, comments? Thus far. Anybody lost? Okay. you might get lost here. Okay, we're gonna talk about clinical history overall. Trust me, it all ties together. So generally, there's about 5 forces or waves of counseling theory, right? And this is not specific, I wasn't gonna like tag it up and do all the things. Y'all can catch my TikTok for that, because I always have some deep dives. But in general, there's like the psychodynamic era, think Freud, all of those things. Then there's like this cognitive wave where we started doing a lot of research, and there's the white bunny, white rat, rat. Okay, I always forget what kind it is. We started doing a lot of research. We started doing some stuff that continues to be empiric, peer-reviewed, because it was easier to study, more science and stuff started here. And then kind of in like the 50s and 70s, we started doing existential stuff, systemic stuff, looking at like other philosophies and things. And then really in the 80s and 90s started doing this like multicultural focus, feminism things started here. And really right now, currently, with waves of new different theories and approaches and integrations of theories with intention and science and things, we're really understanding we're like in a social justice era of creating and treating and looking at new ways to approach people. It's really more social justice and advocacy with the new stuff that's coming out. Okay. Okay. And this is general. Someone's gonna come at me and be like, "Oh, wasn't the 1940s?" It's close enough. We also have our history of the DSM, the Diagnostic Statisticians, the DSM, of when that was created, which is independent and different because there were medical models and how are we going to diagnose and what are we going to do? And so it wasn't called APA initially, American Psychological Association. I forget what it was called before, but they were trying to, how do we format it all, like level the playing field, have consistency with their diagnosing. So they came out with the DSM. The very first one was in 52, 68, 80, 87, 94. This is what I was talking about kind of when I was in school and stuff, DSM-5, and now we are on DSM-5-TR. And it takes 10, 15 years for each new revision to be made. There's conferences, there's hearings, there's debates, there's a whole bunch of stuff. So it's not just like, oh, we need to tweak something. It's a huge panel of people and experts that get together and research and do stuff. So it takes a while, as frustrated as I get sometimes with some of the terminology, especially that I saw working in real life, trying to navigate between these. Whew, it takes a minute. And that makes sense because we want it to be empirically based and with research and consortium of a bunch of experts. But it can be frustrating from the clinical side and from the client side as well to not be reflected accurately or to be dismissed or harmed because of these things in here and this length of time it takes to make changes. Got it? Okay. I'm so glad y'all weren't trained on 4. We remember those days. So if you expand out the theory timelines, we didn't start getting the DSM until around here. So sometimes that impacts what kind of work people are doing where, what kind of treatment people are doing where, kind of what they were trained on. So if we have people that were trained way back here or way over here, again, like I said, people who are like, what do you mean DSM changing and stuff? Well, because they were trained here within the 3 and the 4. So sometimes this can complicate people's clinicians' perspectives and providers' perspectives. I didn't pull all the exact data because it would make the slides too heavy, but there's an aging workforce just in general, right? We're having less children, less people through college and some of those factors. So there are a lot of clinicians who are way older than me, right? There was no MSJCC when I was a student, right? So I had no idea what multicultural social justice counseling competencies were. Now y'all have it in almost every single one of your classes. There's somebody putting in a slide somewhere, right? Outside of your multicultural class. It wasn't a thing at all. I'm actually surprised, not surprised. I did a training, or I was in a panel for like 50 something LPC supervisors in Texas one time, and I mentioned MSJCC for something. Bless you. And the number of people who were like, what's that? What is that? I said, ooh,
Isn't that a requirement of the license?
you just have to get your CEUs for your license. They don't know. Like this for CEUs could count as cultural diversity units.
But isn't MSJCC cultural diversity though?
Yeah.
That's a requirement in Texas. Okay, all right, I'm sorry,
It is required for you to maintain your licensure in Texas as an LPC. And LMFT, it's similar. Is anybody LMFT in here? You're dual, right? Okay, it's similar vibes, but you have to get 24 continuing education hours in order to maintain your license. A certain portion of them, I always forget because I also have supervision hours. I think it's 4.
it's 6
6
and 3 culture diversity.
Thank you. Mine always, again, mine get mixed up because I also have to do the supervision ones. Yeah, so that could be culture diversity in anything. It could be disability. It could be, it doesn't have to be MSJCC flavor.
Gotcha, okay.
And that is changing over this next couple of years.
Mm.
That's also, watch my TikToks. So, yeah, so you might see some people who are older. The average age of a therapist in Texas, let me circle back. I think it was 40 something, 43, 42, that's the average age. It's decreasing, but slowly. So like younger people are coming in. So that means maybe they were trained here. Ish. I don't know. Sometimes there's people who don't understand the history of training and DSM and application and stuff, so. And we see that within treatment for marginalized communities. In my experience. So this is the part where it really gave me the ick. And I knew these, but I put them on a date so y'all can see. DSM, the original one, labeled homosexuality as a sociopathic personality disorder. Take a breath. Did you miss my take a break slide? Sexual orientation disturbance, ego dystonic homosexuality, DSM-3 got a little better, sexual disorder not otherwise specified. But gender identity disorder was still a pathological identity for transgender individuals. In the 4, we still had gender identity disorders, but in 5, it changed over to gender dysphoria. Go ahead.
You know, for like the 1952, like what's the criteria on that?
Gay. I don't know the criteria. I don't have a copy of the original TSM and I could not find one.
I'm wondering, cause that's so like.
Y'all can't tell I'm super casual. It wasn't anything that made sense. The snippets that I've seen, like some of these didn't make sense to me, all of them. Like I had to look up what dystonic means. Dystonic. It means like dysregulated. Yeah. We don't need no $5 words, we use a $1 word, but I don't know. Well, this further, even using this heavy word, this $5 word, is further pathologizing. Right? And where this language fits a little better, I don't use this in my practice, and it's not a pathological identifier. It is a separate non-mental health disorder we need if we're going to provide affirmative care letters to the medical community who are wanting to provide gender affirming surgery, things of that nature. But in general, I don't even use that. Only if I'm supporting a transgender individual who is seeking affirmative care. Because insurance wants it. The doctors need it. WPATH is the association and the designation that a provider needs to have in order to provide the gender affirming services. Anyway, so further questions? Okay. Yeah, this is really heavy and wild. And there wasn't a big change until here, and there was a quick turnaround in DSM land to change it over to sexual disorder not otherwise specified. And again, going back to the history slides of the LGBTQ+ community, that's because of activists from the gay community. Gay psychologists were studying, psychiatrists, and were saying this isn't right. And the gay community has been arguing about equality and stuff since like the 1850s, 1870s. Right, but here's the first couple of, I forgot his name. Psychologist, also gay rights activist, oh, I'm blanking on their name. Had to go testify in front of the APA and stuff and talk about these things and, you know, the board rules, and he had to come masked and use a fake name, like to protect his privacy. Because it was wild.
Have you ever worked with a client who will use some of the language, like maybe not so much the older terms, but like a client may say like, I feel dysphoric sometimes, and whenever I'm dysphoric, I isolate. Have you ever have heard clients like use that language?
Yeah. Yeah, especially if they've been in medical care for a while, or if they've sought affirming care in the past. I have a family friend actually who transitioned, got all of her surgeries and stuff like in the 80s and the 90s, when the surgeries were still really new and, you know, way more dangerous than nowadays. They're still pretty dangerous. But some of the self-talk that she would use, because she had to go through all these things, all these wild assessments, and had to be told she was crazy, quote, crazy and not in her own body and stuff, but for years and years before she would get surgeries. Go ahead.
I found the general criteria for the 1952 DSM, if anyone wants to hear.
What is it?
I don't have like this, they scrubbed like the specific timelines, but the term was used in the DSM-1 to describe a range of conditions characterized by maladaptive personality traits and behaviors that deviate from societal norms, and same-sex attraction and behavior were considered a part of that.
So gay.
Yeah, it was like a laundry list, so basically like any kind of deviance from societal norms
Yeah.
was placed under it as a like a whole umbrella term, but it doesn't give any like time periods or anything, because I think it was pretty well scrubbed.
Yeah.
It'd be a minute to even get to that.
See, y'all know how to search, because sometimes I give up.
It was definitely not easy.
If I'm on the 3rd page of Google, I'm not. I'm not looking for it.
Go to page 3.
If I'm desperate. All right, let me switch gears. But yes, I have had clients, and family friends, and, you know, people I've just known. And then for my clients who come to me for care, a lot of that negative self-talk is what we work on. No, you're not crazy. No, you're not dysphoric. No, you're not, sexual disorder. Or whatever.
Even the word dystonic, I had a bad reaction to medication one time, and it was called dystonia. I was having like
Mm.
contractions in my face.
Mhm.
And I'm trying to understand, like, using the word dystonic, contractions of your ego, like,
Oh,
cause I was having facial contractions, like I couldn't control my mouth.
yeah.
That was called dystonia, that's
Mhm.
dystonic. And I'm wondering if that's like the vibe they were going for, I don't know,
Painful vibe.
yeah.
Gross. Yeah. When I was writing this presentation, I always want to give students the most research and the most data that I could find, because I don't want to skew and just make things political, even though their history, our history of the LGBTQ community comes with inherent political things. So I wanted to go with a broad overarching view, but I'll show you why. Because they're just people. We're just people. I am part of the LGBTQ community. I am bisexual. Whatever, don't matter. We go to therapy just as often for just the same amount of things that other people do too. Most people go to therapy for anxiety. Real close behind it, and sometimes it flip-flops, right? Depending on which research journal you're looking at or which kind of population you're looking at, it'll flip-flop with depression, right? Top 2, anxiety, depression. And then there's not really any good data, because it depends on if you're LMFT land or not, if you're looking at this kind of stuff. And then the age group for adjusting to life. But then the rest is this stuff. People are just people and trying to be people. What our job is as clinicians is to understand and apply what we know through our MSJC lens. Right, understanding that this group, as a marginalized client, I know it looks crappy, I was trying to make it blend. As a marginalized client, has these additional factors, and this can be true for any historically marginalized group. Latinos, Hispanic, Indigenous, Black, women, don't matter. There's these types of things because they're marginalized. Most of the time they're coming to therapy for that stuff. So I'm trying to not further pathologize, knowing that we know all of this stuff. Trying to not pathologize care, but rather inform you. Because this stuff big. But maybe it's just anxiety. Because people are just peopling. Their identity as part of the LGBTQIA+ community either is no importance of why they're in therapy, incidental, or it's the primary reason why they're in therapy. And this can inform how you're working with them through the stuff up here. And again, this is not an exhaustive list, I'm just saying kind of in general, especially at your stage, this is what you're gonna be seeing, those things. I literally, and I wish Jace was here. He's got really great insight as an openly gay counselor. Actually, we had a gay pride open house at our office last week, and he came in drag. So he's definitely got some great insight. He's gorgeous. I can't. He's got clients that are like, yeah, I don't have an identity. Nope, I sleep with men and women. Nope, I don't know. Don't matter. I'm here because my dad died. Cool. We're working how your dad died, like how that's impacting you. The identity has nothing to do with why he's in session. He don't even care that Jay's gay or not. He's like, just let me talk to a male. We got you, boo. So for that client, it's grief, which isn't up here, but it's no importance. They don't matter. And we have some clients where it's incidental, working with relationships. Oh my God, breaking up is so hard, and like I'm changing my life around, I'm graduating college, or I just moved to town and dating sucks, and like, oh my God, the gay scene here? Oh, it's not Austin. So it's, how do you navigate dating, being gay in the area that you're, I got like 4 clients, but it's incidental. It's really the relationships. How are they setting boundaries? How are they communicating? What are they doing in session? What are they doing in life? They just happen to be trying to date while gay. It's incidental. But if it's primary, if their identity as an LGBTQ individual is primary, they're feeling torn, they're having lots of issues coming out to their family or coming out to themselves, or they were recently outed. Against their outing is when you out somebody else. Like, it's real detrimental. How do I manage that? Or how do I work in an office that's all red and there's like pro stuff all over the office and I have to be closeted for safety? Then that is primary. Right? That's life is life and against you. And the anxiety is incidental. I'm gonna let y'all sit with that for a second. How does that flow? How does that feel? My doc students are already clinicians.
I work with a lot of no importance
Mhm.
of it. I've recently had someone reach out to me wanting to, where it was incidental, but it didn't get any further through like email. I've worked with, like I said, I've worked with some that are like, it's no importance, like, yes, I'm a lesbian, or yes, a man. And I'm like, okay, so like this, and they're like, no. I'm like, okay, cool. But I also wonder, is that them testing to see if I care?
Yes.
And I'm just like, this is not about me. Like, I'm here to help you. And if that is a part of like the reason why you're coming, have no problem helping you with that. And so for me, I'm just like, how you love and how I love has nothing to do with me.
Mhm.
Like, these are two different things. And I think they appreciate that and they feel validated when they're like, oh, what do you mean it has nothing, like that? How you live your life is not gonna impact me anyway.
Mhm.
So like when I hear other people and I'm like, what does that have to do with, how is that impacting you? And so that's how I like empower and encourage and validate my clients
Mhm.
that are a part of the LGBTQ population.
Mhm. Yes, they could be testing you. One of the things that I do in my practice, I'm sure it's on a slide somewhere, but someone says, hey, I want counseling. I'm like, cool, what you coming in for? And I start getting their name and stuff. I ask their name and then I ask their pronouns. What are your pronouns? Is that the name that you want to use? Because sometimes they'll give me their government name first. Girl, why are you in and out? But you probably heard that. Actually. You what? Don't worry. That's fine. Actually. Just yell. Anna, you're not muted. Are you muted now? Okay. Oh,
There's a chat.
there's a chat. Okay, okay.
That's probably why she's in and out. It's not really robotic. It's probably like dropping.
Oh, yeah.
Signal's probably just dropping in and coming back in.
Ah, that's what I like Zoom. Okay.
Yeah, Zoom does that to me too.
¿Cómo se? Where was I?
Talking about clients testing us
Testing,
and
yeah.
telling them
Testing us.
their pronouns.
Yeah, so I'll say, you know, so what's your name? My name is Anna. Okay, what are your pronouns? Oh. I have some people who are like, what's that? She, he, oh, okay, and then they tell me, and that doesn't mean nothing to them. When it matters, I can hear it. Oh, they, them, she, they. Or, and then since I asked the follow-up question, is that the name that you want to use, especially if they've given me a different pronoun? Or what, if they gave me that reaction, what name do you want to use? Oh, Gabriel. That's my kid's name, I'm just throwing names out there. Okay. Gotcha. On a government name, pronoun he, him, I don't know. And then Gabriel. And that's how I enter it in the system. When it matters, it's important. And I do have people call and like, they'll give me a bunch of answers, like just, my name's Gabriel. Yeah, I go by Gabe, he, him. This actually happened a few weeks ago. I assigned them to our student, Michelle, and caller said, Michelle. So they're scheduled, we're talking about scheduling stuff. So Michelle, she, her, he, she, they were testing me. I was like, oh, she uses she, her pronouns. If she wants to share her identities or anything like that with you, she can do that in session. I do want to let you know that we are safe zone trained. We are all allies with the LGBTQ community if we are not a part of the community. And they were like, oh, code switching turned off. That's true. They were comfortable. Oh, girl, okay. Yeah, I come in. I'm coming that day. So they can be testing me. And an extra asterisk, because I'm gonna parking lot myself after this. It may not be important until they start doing the work. And then it come out. Then it might be primary. Oh, I'm coming in because I'm anxious. No, it has nothing to do with my identity. Oh, it sure do. We just didn't know it yet. Parking lot myself. Okay.
That's quick.
Sometimes it does, sometimes it doesn't. So I am going to talk about some evidence-based treatments. And it's 11 o'clock. I do have to leave a little early because I have a crisis client coming in at 1. So I'm going to try to be done by 12:40. It gives me 15 minutes from here to get to my office. Because the world's on fire. Some evidence-based treatments. Now, here's the thing. Some treatments are not meant to be researched. Some are easier to research than others. It's super easy to research CBT and CBT land kind of flavors of theories. It's really harder to look at relational components or relational theories or psychodynamic theories just from the, you need to do qualitative studies with that. Like get this people's stories, drill down the data and their themes. It is much easier to do. How efficacious was this? You know, a survey is a lot easier than sitting down with hundreds of people to gather stories and to see where that flows, just the nature of the theories. So, just wanted to put that out there. Remember we had this history? Well, if we weren't really aware in social justice-y and system-y until about here, but this is when we got the DSM-2. So this is when we had that weighted negative language. So some of the things here may or may not be as good. I don't know. But back here, sometimes when I teach this, I'm like, they're just vibing. They're just vibing in sessions. Yak therapy. Yak therapy is what Therapy Talk says. You're just yapping. It's good. I don't care which theory, which force you use. It don't matter. But I know y'all want us to know what's the most useful. It depends. It depends, and I'm going to tell you why. People are just peopling, trying to live their best life, trying to heal. The same types of treatments that work with cisgender or heterosexual individuals can work just as well. What matters is how the clinician uses that theory and what they're intentional about. Dr. Anna, why do you have houses on there? Why do you have a tree house? Because my analogy when I teach and talk about theories and how to use them is that this is my client's house. When we work with them as a clinician, they are inviting us into their home. They're inviting us into their space. Now, sometimes we're just invited into the living room, that little front room. We ain't invited for coffee. We're just right there. Sometimes we're not invited. We're not gonna go into their bathroom, just start rifling through drawers and stuff. I mean, I don't know. Just thought about that. Most you are not gonna go into their bathrooms and start digging deep. Maybe that's where they hide their trauma in their back closets. You know, and then we work our way through and we do things. And we have our little tool bag, our little bag of stuff that we have with us, and that's our theory. This is their house, we're bringing our theories in with us. And that's how we're going to work with them. We understand as the clinicians with the toolbox that if this were CBT lens, we would know that there's thoughts and emotions and behaviors, right, that hold this thing up. And that there's irrational beliefs that are messing with the house and making the foundation all shaky. Or we know if we're trauma informed, we're not just gonna kick down the door and come in and I'm rifling through their bathroom. I know, I needed to kick my butt. And, or if we're systems based, we're gonna know, we can't even enter this door. Maybe there is no door, right? The foundation's shoddy, or maybe we need more community support up the house before we even get in there with our tool bag of stuff. Is that vibe? And I don't care if it's a tree house or a boathouse. Same things still stand. I don't care what kind of house that person has. There's still a foundation holding up the house. There's still like a different kind of foundation you need to be buoyed, to be, I don't know, to float in the water. I don't care, don't matter. We're still going into their home with our tool bag and our things. So we just need to be informed about what we're using because we're entering their space. Now, I'm not gonna come in, or at least, I don't know if y'all ever had maintenance come to your apartment and all kinds of stuff, just coming in and knocking holes in walls, or like order somebody to come into your house and like try to fix something. And they just come like, we just whack stuff around. We just start hammering stuff, not using the right tools. It's our job to make sure that we know what we're using in our toolbox. We're not just hammering stuff to hammer because it's cute. and that we're working with our client. Do you want wallpaper here? Or do you want to paint this wall? What do you want to do? It's your space. So it depends on you as a clinician. Just like we can't force treatment on clients, we can't force clinicians to only use one model or one approach because it's going to work with that population, because people are just people. I need a breath and I'm parking out myself. Our job as privileged therapists is to, well, no, back up. Because I have lots of marginalizations, but I also have lots of privilege. I'm a doctor. I own a home. I'm so light skinned, all of those things, right? But overall, privileged therapists who are trying to find out all of this information when they are not part of the population can be bad for clients. So I'm glad that y'all are here. I know y'all had to come. But if you had the opportunity to do other trainings further than this, with our privilege, if we are not in the community and we're centering ourselves, trying to find that knowledge, we can do some harm. Okay? Inaccurate assumptions. Oh, I took all those classes. I know what it means to be gay. No, you don't. It can reinforce some of those therapist-client imbalances that you see when the privileged clinician takes the role of expert because they've had some classes. And it can really limit the opportunities for clients to talk about their identity or talk about their experiences. Oh, I know you're gay. Oh, that means that's what you're coming to therapy for. Well, no, I just identified as that. It don't matter. So beware. You know, even if you are in the community, like myself, again, I'm bisexual, and I am in the safest, part of the community, and that I'm in a cis heteronormative appearing relationship. My husband's tall, big old white guy. You know, no one's gonna clock me. I can be as closeted as I want to be. And I have been, depending on where I work. And it's easy, because it's not my ex-wife. You know, my big old tall husband here with my kid. No one blocks me. So I also have a lot of privilege, even being within the community. Just like being Latina. I'm light skinned. My Spanish is trash, so I talk all English. I have a lot of privilege in that community. And I can still do harm. Vibin? Okay, Lena, tell me where I'm wrong. No. All right. So what I encourage is not expertise just in the populations that you're serving, especially the LGBTQIA population, but it's looking at focusing on you and your application and understanding, are you scared? Are you scared to get it wrong? I'm scared to get it wrong all the time, and I do get it wrong. I didn't know what a ferial was. Like identifying like with fairies, like you know what, I'm gonna stop because I'm wrong. See me, I'm wrong. I'm uncertain about it, but I'm not scared about it. I just know I need to research it more. We need to focus on facilitating that trust, regardless of which orientation you come from. Regardless of when or where, when you're trained, or what kind of language those people use, this is important, right? Reducing fears, sitting with clients, being comfortable with being uncomfortable, facilitating trust, that rapport with the clients. Continuously training. This training does not make you an expert. Hard stop. Gaining experience in the field and not going in with a blind attitude. So that can't be colorblind. I don't think there's a term for gay blind. Like, I don't see orientation, I don't see identity, I don't see color. We can't have none of that. That was a hard eye roll. Yeah, we can't have that. Because it matters somewhere, somehow. Even if it's not the immediate or primary concern. Okay. In order to have clinical success with clients, especially with the LGBTQIA plus community, it's about rapport. Do they feel comfortable with you? Do they trust you? It's about doing those things. And so I do say like, hey, I'm bi, but it's a big old white man, so I'm not gonna know what it's like to be a trans woman. Period. Approaching those things, bracketing my assumptions and things, like when we had a kiddo recently tell me an identity, and I was like, I don't know what that is. But I make a little mental note of it. I gotta study that later. Also, I didn't know what this meant.
Oh.
I had a client that was like, that eight. I was like, is this a different language? I,
What is it?
like you ate.
Sorry, what does that mean?
It's a compliment.
It's a compliment. I was reflecting something back for the client that they had not understood for themselves before. And they went, I hate you.
Like you ain't there.
Like it landed.
Yeah, yeah.
In the clinical sense, it landed, but it hit, like, it made a whole lot of sense. And like, you're right, you're right.
Definitely how my parents felt when I was growing up.
The what?
It's how my parents felt when I was growing up.
It's
It's just now hitting me, like with the next generation. I'm like, I don't know. Maybe this.
I don't know what any,
You know, cause I'm like, what? That is.
Yeah.
I was looking at little new cousins, so I was like, I know what that means over.
oh, I get a 20-year-old and I'm like, oh, I'm not gonna know anything. Especially, and in marginalized communities, there are different subsets of language and slang. And some of the LGBTQ slang is from and derived and historically linked to AAVE and like some of the drag ball eras and like some of the queens and some of that stuff. And like, this is real old. Like, this is real old from Queenland. Like, Queen's been doing this for years. I just shook because I never, see, even shook. I was shook because I was like, but you told me you hate me. That's right, we're we're gonna go with it. And that's about the report. I didn't know what they were saying. Whatever. Parking lot. Making sure you're having this stuff to do all these other things. Because, and there's not enough marginalized individuals. I think 50, in Texas, I think it's 54% of therapists are white. There is no clear data on LGBTQIA+ status. We are in Texas, so not sure if people feel comfortable acknowledging or not. No, said it. I don't know. Unless you're like my clinician Jace, who was like, you have permission to say I'm gay. And one of his pictures on our website is him in drag, so. Go. Again, moving on to what our focus should be, is making no assumptions. Again, is their identity of no importance, incidental, or primary? And then considering and understanding microaggressions and discrimination within therapeutic relationships is real. Amy was talking about, who's kidding? I don't remember if everybody was in here for the panel or not, but, oh, I just can't see them because I don't understand this two moms thing. That's painful. Us not asking pronouns, us not using their name, not preferred name, their name is a microaggression. We have no problem saying, oh, your name's Gabriel? Do you go by Gabe? Easy peasy, lemon squeezy, right? But Anna, who wants to go by Joel, oh, I don't know if I keep stumbling. I mean Anna, I mean Joel, I mean Anna, I mean, you slip once or twice, cool. You slip once or twice on, oh, it's not she, her, it's she, they. Okay, my bad. She, they. Once my apologies, move on. You don't keep messing up. And clients experience that a lot. Those are microaggressions and discrimination of like, oh, well, I can't see you, or I don't want you to come dressed effeminate today, or dressed masked today, or whatever. There's also different conceptualizations of gender identity between client and therapist. I have a couple of clients, actually in our support group, we have this little, I should have put pictures, that would be cute. Of like, I have a cute bow with like little pins on it with like pronouns, and one of them says, it depends. I don't know, they come in and I'm like, are we queen today? Or are we king today? What are we doing? Nothing. Okay. Come on in, on. Because their identity is so fluid and it's no importance, it's how they're vibing that day, right? So I need to understand and work with that client. How do I greet you? How are we gonna set up sessions? How are we gonna start the group? And that's what we decided on. Are you king or are you queen today? To help the rest of the group navigate that stuff with them. So I'm leading for, anyway. So just understanding that sometimes it's different. Check, it's important to also check your biases. Amy talked about biases too. We don't know what we're biased against until we examine what we are biased against. And there are new things that come out all the time. Like I don't know what's really new for me. Oh, video game stuff is driving me wild lately. I know, I know, because I'm so confused. I'm so confused about the video game stuff. You know, having I'm just using this as an example, it's not LGBTQ related, but like, your friend literally lives 2 blocks away. Why are you on the headset talking to him? Like, he can walk over, you can walk over there.
That generation of outside, they're allergic.
I know, they're allergic to outside. I'm like, get on my house. Like, and like, again, it was his birthday party, so there's a bunch of little dudes over at my house. I'm like, why'd y'all bring all your VR sets? Like, why y'all playing? I don't understand. So I have lots of biases and assumptions that I'm making about their communication skills and about what they're doing. And all of these, I don't know. I don't know what I'm assuming. So that's just a weird example. That's just from this past week. I can't think of a great one right now. But also positions about policy and public debates. I don't know what I'm against until I see it come out in the news. And even then I'm like, ooh, I gotta read more. Stuff like that. And that's gonna impact clients, it's gonna impact worldviews, it's gonna impact what they're stressed about, regardless of identity, right? So I don't know, just check your biases about stuff. Cause that's, yeah. And avoiding can seem counter to affirming. Oh, I'm just gonna ask you your pronouns because it's on our intake form, but then I'm going to avoid the topic. Oh, well, now I don't feel safe. Now I tested the waters and you're never gonna bring it up again? Okay. Heard. It can feel very dismissive to avoid it. I'm talking about y'all. Let's talk about theory. Minority stress theory. Are y'all all in practicum or internship? Has anyone heard of minority stress theory before? Huh?
But I'm just a minority bitch.
That's all I know. There's lots of reasons why when we're minorities, we're stressed. And minority stress theory is something that you can use and integrate and learn about. Y'all have to do some homework. I can't teach y'all everything in 2.5 hours or whatever. There are things that negatively impact mental health from lots of the research that's done in minority stress theory. So experiences are early, ongoing, and undermine mental health. Microaggressions, macroaggressions, systemic stigmas, systemic oppression, negatively over and over and over again, can lead to things like identity-based victimization, peer bullying and rejection. Or included in the LGBTQ community is family non-acceptance. So this is for minority stress overall, but there are some factors that are more impactful within the LGBTQ community. The family non-acceptance and the identity-based victimization being key. And that should be flipped actually. Identity-based victimization is more under the LGBTQ. And sometimes developing the theory calls them coping adaptations and really stresses on there's no good or bad coping, it's just what you're doing in the moment. Because there's limits and realities of what you can and can't do. But if they're chronic, if they're inflexible over time, it can lead to negative negative self-schemas, shame, hypervigilance, things of that nature. But I was wondering if my office is calling.
Actually working with a client, we just had a breakthrough. I'm using CBT on her, which is not my go-to.
Mhm.
And we just had a breakthrough of her understanding that she shames herself.
Mhm.
And she just realized that she shames herself because she went to a Catholic school. And that's where she was struggling to come out of the closet, and she came out of the closet,
Mhm.
and her parents were conservatives. And so they weren't very accepting of her, but even not funny, all of her siblings are a part of the community. And so we just kind of like realized she shames herself to not speak up,
Mhm.
to not say anything because of how they basically trained her to be quiet.
Yep.
In her high school. And I was like, let's talk about that. She was like, I said next week.
Yeah.
We'll talk about that next time. And she was like, okay. I said, because that's something deep and heavy that you didn't even realize it was for us to be in, and that's really working. Because she was saying that she think it was, and I was like, no, that's not it. Communication.
Mm.
She was like, it's communication with me and my partner. And I'm like, that was cute. It was a good starter,
Mhm.
but that's not what that is. I was like, you're shaming and guilting yourself. And she was like, oh. And so, yeah.
So her coping adaptations were like, let me zip, let me, nope.
Because it makes me uncomfortable. I don't want to make anyone outside of me uncomfortable, but it's okay to make me uncomfortable.
Mhm.
I was like, no, we're not doing that.
Chronic,
Mm-hmm.
and that's ongoing.
I think family is now just, they're learning to just accept her.
Mm.
Well, now that all three of their daughters are a part of the community.
You got no choice now.
Right? And so I think they're now just kind of just meeting her where she's at and just kind of accepting it. Before it was like rejection, you're an abomination, blah, 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 all of those things. So.
Mhm.
Crazy word. Listen,
Mhm.
listen,
Mhm.
those are the religious people that's not even religious. I'm like, did you read that whole chapter? That whole chapter. I don't think you read that whole, you're just picking it.
Mhm.
It's totally fine.
So through understanding that minority stress response or any minority stress response, being anxious is that's fine. Of course you're anxious. You've heard all these negative things about yourself and you live with this negative schema. It can be empowering to cope with these consequences that they're experiencing. And validating the impact. Oh, y'all can get over it, y'all can just learn to communicate better. No, that stuff hurt. And now it's deep-seated. And then how to build relationships outside of family or in other ways, or building the relationships in family to support authenticity. You will find many, many, many people within the LGBTQ community who have found family outside of family and developed that community. And that's really important and impactful and helpful. And there's a lot of strengths within each community, right? It's always challenging to think about how to train on marginalized groups without being so down, because that's the way we're taught, is like, oh, these are the deficits and we got to help them uplift and stuff. But there's already inherently beautiful and unique strengths within each marginalized community, and the LGBTQ LGBTQ community is one of those too. This is a big one, understanding and validating intersectional identities. That's source of stress and resilience, stress and resilience. But we just talked about gay. We didn't say what gender, what demographic, I mean, what socioeconomic status. Try not to cough. All of those things, I think Amy touched on it too. You know, there's so many different cross sections and crosshairs that you can have ostracism from your family for being lesbian and also have the impacts of systemic racism because you're Black, right? So how do those things all come together? Minority stress. So I'm gonna talk about theory again, still. LGBTQ folks get there's about the equal results for standard CBT and DBT, especially if we're looking at it's not a priority for them or it's just kind of incidental for their identity to be part of treatment. It's about the same. Some of the data is a little skewed because if you're in a research setting versus a community setting, but overall, they both reduce suicide attempts, improve general functioning, and treatment can be fairly consistent. So CBT and DBT, pretty good. Relational theories are pretty good, especially if someone is looking at kind of incidental and then maybe primary need for their identity to be in treatment. Like emotion-focused therapies, it's all attachment stuff. It's all attachment relationship stuff. It's all about finding those emotions and going through them and, looking at literally emotional experiences. So some of those things are really good, especially EFT with couples, can be good. You're looking at the primary, secondary, you're looking at all that stuff in there. It's good. It works. And at pretty similar rates. I wanted to dive for a minute on CBT because it is one of the most readily researched theories, right? We do a lot of research with CBT and DBT and stuff, but if someone has no importance for their identity, as you were, keep going. You can be looking at the unhealthy ways of thinking, patterns of behavior. If it's incidental that their identity, if their reason for therapy is incidentally attached to their identity, I got that, let me stop. If they're in the incidental level, maybe they need to talk about their identity or their sexual orientation. Double check yourself. Are you adding those components of minority stress theory into it, for example? Like, are you acknowledging that their painful reality and microaggressions are for real? Or there's anti-trans legislation, right? It's not this thinking stuff. It's not a distortion in thinking that I'm going to be harassed or maybe killed because I'm trans and not passing, which is a whole different thing in the community, right? That's a very real fear. There's a fear if I come out. That is not distorted thinking that you can just challenge and recognize. So straight up CBT is not going to work if it's the primary, and just be mindful and careful when you're looking at this incidental need here. I'm going to pause. Does that make sense? Or what questions do you have here? Why that wouldn't be so? Is anybody here UCBT? Who's a CBT fan? Well, you should be like this. That's right. Yeah. So how does this feel and sit with what I'm saying from your perspective as a CBT? Either of you. Dr. I raised his hand too.
No, okay. This is gonna sound bad when I say it. However, it's an easy go-to because I'm foundational Gestalt.
Mm.
Like, let's talk about how we're feeling now, because how you're feeling now and how you're feeling outside of my office is two totally different things.
Mhm.
And so like when you're outside of my virtual office, like you have to deal with the environment and how that's impacting you, and you compact that.
Mhm.
So I want to know how you're feeling now so we can unpack that and then explore it. CBT helps me understand their thought process, and it helps them understand their thought process. And so it's not all feely,
Mhm.
right? So it's an easy go-to when like a team not working.
Mhm.
Or they're not a feely person. So it's an easy go-to, and it helps them. I don't know, think about it. It helps them understand them a little bit better.
Mhm.
When they don't want to be feely, because I got a couple of clients, I was like, I don't want to talk about that. I'm like, hurtful. All right, let's go to how you process things.
Mhm.
So CBT is really an easy go-to, but it's not my favorite. Like, I want to let's talk about your feelings. Not talk about them, but like, what are you feeling and why do you think you're feeling them?
Mhm. Mhm.
Because that takes you deep into the core, but some people aren't ready for that. So,
Well, Gestalt helps you to understand like the interactions and the other 167 hours in the week that they have in their history and stuff, just by nature. So that you don't have to use minority stress theory because you already have that foundation of kind of the philosophical world of the other and the experience, all of that stuff to bring into session.
but for CBT, integrating it with minority stress
Mhm.
theory, first of all, didn't know that was theory. I just thought that was just me in the world. But I think it is a very good foundation to like help them understand, like help them validate what they're feeling and experiencing. And that they can also understand that they can change their point of view, but they can't change.
Yep.
I always tell people that, like, what can we change? Well, they, no.
Yeah, no,
Can't
that
change them.
not them, boo.
We can
You.
change our perspective of things, but, so I always like to empower my clients, and so sometimes empowering them in their thought process. So I love my work. I'm gonna do more research.
Dr. I.
I was just gonna ask, could you maybe just help, like, maybe restate or revisit primary, like I guess like the X kind of represents like reservations for using CBT for those who are seeking care, urban care when the issues are primary?
Yes.
Okay. Could you like maybe just kind of like elaborate a little bit?
Yeah, so when using straight up CBT, there is affirmative of LGBTQ affirming CBT. And there's starting to do more research, you know, they just starting to do those kinds of things, but if you're using just straight up CBT, and I'm thinking from a student perspective as well, you're just learning the foundations of it. Some of these core principles and how you want to change behavioral patterns can really go against this person with their primary need being their identity and their sexual orientation, because they're wanting people to learn to face your fears instead of avoiding them, for example, under changing their behavioral patterns. And I don't want to face my oppressor. I don't want to face the realities that can be more harmful. It is better to avoid them, honestly. I'm going to avoid going to my family's house because the last time they beat me up, right? Or something like that. And just some of the ways of like looking at changing thinking. If your primary need for therapy is that you're trying to figure out your identity and kind of where you fit in the world, we can't understand the behaviors and motivations of others who hate us and want us to die. There's no understand what.
So like maybe then somebody who may traditionally use CBT, if they encounter a client who might be seeking treatment and they're trying to process aspects of themselves that are primary, they may not be necessarily well trained or skilled to
Mhm.
address some of those issues sensitively. And so they may do things unintentionally or intentionally, right, by imposing on them or leading them in a direction that may not be safe enough.
Yep.
Right? Because I'm thinking of a situation where I used CBT and it was, I think, helpful for this client. So this client identified as, well, really, they were also, kind of a side note, they didn't like the label transgender.
Sure.
But, they were transitioning from male to female, right? And so, her parents were not accepting at all whatsoever. And so she would have beliefs like, my parents don't love me, my parents hate me, they want nothing to do with me, I don't want to be home. And she would engage in a lot of risky behaviors, would run away, would hurt herself. And so CBT, I felt like, was helpful, as far as helping her, like, examine and reflect on her thoughts and how certain experiences she's had may have led her to have these conclusions. And then also, like, to strengthen her self-esteem and her beliefs about herself, and how her sense of worth and value isn't necessarily anchored on those experiences, right? I feel like it's helpful in that context, but I'm trying to see, was that more incidental or is it primary? She also, and I'm thinking of some other clients too, who they came in and they're like, the person I see in the mirror and the person I feel don't match, and I don't like that feeling. Like, every time I look at myself, I'm like disgusted with myself, is how she would like explain it, right? And so, like, to me, that seems like more of a primary issue.
It could
And
be.
so I feel like there are some nuances, right? Like, so I definitely agree with what you're saying, is that if you traditionally go with maybe some of the more direct approach with CBT and you're not really trained in like affirmative care, you may not be sensitive enough to really maybe broach certain issues or like process certain issues in a way that could be safe. I guess that kind of
Yes.
helps, but okay.
Yes. Because some of the limitations of CBT, like you said, are really focused on some of the external and the reactions and things of that nature. And there's not enough nuance in some of the more deep emotional components of our relationships with ourselves. I find when someone's needs are more kind of primary focused, or sometimes instant, I don't know. And for each person, it's gonna feel a little different. I do use some components of CBT sometimes, but I tend to lean more towards SFBT, solution focused, briefer therapies, because that's more tangible, it's more here and now. It's not like challenging everything all the time, it's like finding the wins. And especially working from this lens of, no, you're not just trying to like change your habits, you're fighting against a big system. And that's where I find a big discrepancy there. But they're doing some good stuff with, I couldn't find enough data to bring you. We'll talk about that in a minute. About the affirming CBT, it's so new and they're still doing lots of qualitative studies. There's not enough longitudinal studies on it yet. I'm looking forward to it because it does bring in components of minority stress theory and intersectionality, like Crenshaw and those kinds of things, and mindfulness into it. So I'm hopeful for it. I'm looking forward to reading more, but I don't have enough information to give you, so I didn't add it. Go ahead.
There is, I was just gonna say, like, there's, like LGBTQIA plus focus TFCBT and cognitive processing therapy. I don't know if you've seen some of those
Yes.
manuals, and I wonder if maybe, because those are kind of like CBT based, as I wonder if those, if there's literature maybe that might relate to the effectiveness of those modalities that seem to have kind of tailored the interventions.
Yes. And we're gonna, after this part, we're gonna parking lot it. There's differences among intersectional groups. So they're still doing research and data on LGBT as an umbrella. And there's some research on like Black men who are gay, or Latino men who are gay together with Black men. And there's some differences, and like some of it's not very valid and some of it's not very good, like it doesn't help. Like there's like an esteem model, and then there's like a stare model that they're using underneath some of that stuff. And I'm looking forward to seeing more, because it's still so either umbrella or so niche that it's hard to see efficacy across the board for some of the things. Does that make sense, Dr. Wright?
Thank you.
what I use is relational cultural theory. So I come up from a relational cultural theory background. I'm on the hunt for a new theory, but this one fits for now. It's a feminist-based theory. So this is what I use. Oh,
No, I was just agreeing with her. About like feminist.
I don't,
I know, I got it. I'm.
I love RCT, but feminist theory,
I know, sometimes. That's a different training. There's some issues with it, and this gives me a starting off jumping point that I use by integrating minority stress theory and then using solution focused brief therapy in my sessions, kind of depending on what the client needs. Because it's really, really focused on like, the world's on fire, systems are trying to hurt you, you're oppressed, let's go. And I really focus a lot of my rapport building and client focus on, you know, let's be clear about our each other and our relationships and how do we connect and like, let's empower you, let's improve your self-worth. I'm looking at how are you connected, disconnected from people? How are you disconnected from society? How are you connected to your community? So those are two different things. And all of that stuff, and I'm really, really mindful of the power in the relationships and not wanting to take power away from my clients who typically have experienced lots of power being stolen from them, especially from intersectional identities within the LGBT community. Never assuming, always asking, and not putting the responsibility on them for them to teach me. Just like I'm like, I don't know, I'm gonna write that down. I'll come back next week. So, I mean, if it's of no importance, their identity is of no importance of why they're coming to therapy. For some people, this actually isn't enough. That's why I have to use another theory. Because if it doesn't matter to them, they're just like, I just live as an anxious person. Me just being like, vibes. Yep, society oppresses you. She's like, I don't care about society. Like, I care that I can't drive. Gotcha. But the avenue is always open, especially if it's of incidental importance. Again, they're struggling with relationships, trying to date while gay, trying to navigate life while a lesbian with neurodivergence and trying to date. Like this works really well, where it's just kind of part of the process of understanding how they're viewed by other people and where they haven't had connections before. Can it be helpful? If it's their primary reason for coming to therapy is their identity and navigating their sexual orientation and things of that nature. It depends on the client, right? For some, they do still need additional support from other avenues of trying to reduce other symptomology or to improve areas of their life. And I find that it does have a good foundation. There's a lot of research and data that relational theories do help because you have that understanding, you're trying to provide that foundation for them within the sessions. But it may not always be. Maybe they need more. Maybe they need a different expert than me. So maybe. Wow, I forgot we were talking about integrated care. That was the whole point. I'm glad that there's a slide to tell me to transition. What time do we have?
11:46.
We'll get there. Okay. I forgot we were talking about integrated care. So an affirmative approach, we need to know that there's just a disproportionate experience of negative reactions. That is not always personal pathology, especially as the DSM said before, nor is it minority stress reactions. You're not always, we need to understand that clients, just people trying to people. It's not always because something is wrong with them. They have a personal pathology or a diagnosis. Sometimes it's because of systems. There's too many structural burdens placed on the stigmatized people. Anti-LGBTQ laws, policies, systemic rejection, structural non-acceptance, physical and emotional victimization in our schools and our workplaces, in religious settings, and just understanding that just being affirming can be supportive, right? It's not always something's wrong with the person, something's wrong with the system. does not help that someone is trying to navigate a system that is harmful and broken. Period. When I do presentations, I have like my Zotero and all that stuff with all like my easy access references. And then I add to it as I go, you know. And it takes what? I mean, I guess depending on the journal, it takes 2 to 3 years sometimes to get published. I mean, I don't know, the biggest backlog that, I don't know, a year is the longest one that I've been on a backlog of like waiting before published. What's the biggest one you've seen, Dr. I?
Yeah, about 2 years.
2 years.
Yeah.
So they're getting their data from somewhere to do the articles. So I find a great article, I'm like, yep, goes to my Zotero, goes to my favorite folder, whatever, I have it all organized, right? When I do a presentation, let me pull up fresh data. So I have that article as a reference, but I'm still gonna double check the data to see if there's like a new edition, right? Like, say they pulled data from the 2020 CDC something. Let me see if, I don't know what their yearly cycle is, maybe they come out every 2 years with data, whatever. So let me go to CDC and see where they have the data from. This is what happened the past week when I was trying to refresh my data. This is from the CDC website. Yes. Can you read it? Per report order, HHS is required to restore this website as of February 14th. Any information on this page promoting gender ideology is extremely inaccurate and disconnected from the immutable biological reality that there are 2 sexes, male and female. The Trump administration rejects gender ideology and condemns the harms it causes to children by promoting their chemical and surgical mutilation and to women by depriving them of their dignity, safety, well-being, and opportunities. This page does not reflect biological reality, and therefore the administration and this department rejects it. Everybody take a restorative breath with me. HHS, Health and Human Services, .gov also has similar messaging. Trevor Project, for example, has some great articles and, okay, let me just bypass this, let me go there. Well, shit, I mean, crap. Their source data was here. So this, I don't remember what I was looking for, but I just screenshot one of them. I kept coming into roadblocks. So go ahead.
So like after this, do you think it would get to the point where it's like gender affirming care and stuff like that will be completely taken out of the picture in totality, like made completely illegal? Like you think it's
It's illegal for children in Texas. So, I don't know. It depends. So after this page, I should have screenshot the rest of it. It says article not found. Or some of the articles, depending on what kind of mixed data is in there, the data is still there, but some of the references aren't there. So if we are to provide efficacious care, we need data. And maybe I'm just extra in that when I do a presentation, I'm gonna pull up, oh, that's 2020 data. Let me see if there's 23 or 24 available. Maybe I'm just extra. That's why I came across this, because I'm not in school right now, so I ain't doing no papers, and I'm not writing any articles this year, so I'm not pulling data. So maybe I'm just extra, because I wouldn't have known if I wasn't trying to refresh my data. So it depends, but this is some of the reasons why understanding being affirmative with care can be challenging. Because I come with receipts, like I'm gonna come through, like I'm not just gonna be like saying stuff. And that gets harder and harder. There's a couple of other websites, I forget which one, because I was crashing out. I was all over the place. Where the data is there, but certain sections are taken out. So now the cumulative data is skewed because the numbers are missing. Dr. I is very quant, so I think he's vibing with what I'm saying right now.
Yeah.
Like some of the data is messed up because it's missing some of the demographic data, and so I'm very qual. I was trying to read it and I was so confused. I said, wait a minute, why is this? It can get really icky. So this is systemic. This is oppressive. How do we provide care? It's challenging. Take a breath. Because in integrated care, we are working within a medical model system, which very heavily relies on data from places like the CDC and from HHS and all of these things. And there's even different types of integration when you're looking at care. There's only 2 or 3 places in Corpus that are truly integrated. Because we have some places that are coordinated. Oh. Like, I'm a behavioral health office, right? And I talk with some nurse practitioners and psychiatrists and stuff. But we have to have consent forms and all kinds of things, like we're 2 individual entities. So we're not integrated. And then we have things that are co-located, right? So primary care and behavioral health care are talking to each other, but they each have separate charts, right? They still have to have consents and do things. And then there's truly integrative care where there's one treatment plan, one chart, doctors and providers can see all the things. It's that back and forth. Kind of like when you're in a hospital, the oncologist can see what the rheumatologist said and can see what the nurses said, all of this stuff and behavioral health can all see together. So we really only have like Amistad, cost of and wellness, keep some separate charts. The hospitals, of course, if they have behavioral health, it's all integrated. But we don't have very many that's truly integrated. So if you're co-located or working from this kind of integration approach or collaborative approach, different systems, different definitions, different datas, different things, where in a truly integrative setting, you can see, are they using pronouns? Are they using client name? That kind of stuff. Is there consistency? Where these things you can't tell. Right? This is ideal if behavioral health is the same weight as the medical care. I think we're going to talk about that. In working with an LGBTQ population and thinking about integrated care, we also need to be really, really considering social determinants of health. We are not social workers, so unfortunately, we don't get a whole classes on this. This is a component that's missing from LPC land. If you're LMFT or couples, or you're really into families and stuff, you kind of get some flavors of social determinants of health, understanding more systems than just general LBC land. Okay. This is the systemic stuff. Social determinants of health. Do people have access to economic stability? Is their neighborhood safe? Do they have transportation? Our bus system here is rowdy. It can take 2-3 hours to get across town with 3 transfers. It's wild. What is their education level, their literacy level, their primary language? Do they have access to food? Oh my gosh. And right now, people are in some bigger cities are being advised not to go to food pantries because there's raids and things of that nature for Latino populations. If you're also LGBTQ, there can be some complications there. Do you have, and then, but of course your blood sugar is all messed up because you ain't got no real food, but you can't get to the pantry. You know, etc. Support systems, healthcare, all of these things. Because social determinants of health are things that medical providers look at. Medical providers are trained in some flavors and some contexts, depending how old they are, how long they've been training, in some flavors of SDOH. This is why when they think about like, I haven't worked in a medical setting in a while. ADLs, like activities of daily living. It also includes like, do you have access to the food that you're trying to feed yourself and that kind of stuff. So we are just one component. Remember, ideal is the integrated. We are just one component of the whole client's reality and system. Their access to food, their neighborhood, their transportation, the systems that are hanging over them, that they're navigating, their finances, all of that stuff. We are just one part. They're with us for 1 hour and there's 168 hours in the week. And that's assuming they come weekly. There's 167 other hours that they had to navigate and try to figure out stuff. So what do we do? I'm so sorry. Sorry, people. Online. What is our role then? In affirmative integrative care, what do we do? I don't care which theory you use. I don't care which approach you use. I shouldn't say I don't care. It really has no impact upon which theory you use. It's that you're going to have these roles. You're going to be trying to interrupt and reduce some of those barriers, challenges, and realities for their mental health treatment within that integrated system. It could just be something like, hey, patient Anna's pronouns are they, them. Right, just interrupting some of those inequities and stuff that they're facing and understanding and reducing some of the barriers and challenges that they may experience. Also educating and advocating. So from a physical healthcare provider, there's lots of research that says if you can provide someone gender affirming care and reduce those barriers to transition, you will greatly improve mental health progress, mental health success, reduce suicidality, things of that nature. So as a mental health provider, you can educate and advocate for your client to those medical providers about those things, how they can support transgender clients. They may not be an expert. They're probably not WPATH certified, or however you say it, to provide those surgeries and that care, but can we get that referral for them? You ain't got to do it, just can we get the referral for them to find that care? And then be consistent over time. If you're going to correct Dr. I on how to use someone's pronouns, are you also going to correct Lena? Are you also going to correct me? Be consistent in that advocacy and how you care and how you communicate for everybody. I don't care if you don't like that client. You still better correct me if I use their pronouns wrong. Vibes. And understand where you stand. This training does not make you an expert. Hard stop. There is a difference between being a clinician inside of any setting, but especially within an integrated care setting, on whether you are friendly or affirming. I see this, y'all, I see this stuff all the time everywhere in marketing. We're LGBTQ affirming. Yeah, but there's nowhere in your paperwork to ask for pronouns. But there's nothing in your paperwork to say that you can provide services or that you've had training or anything. Maybe that means you're friendly. There is a difference. And this is marketing nuance. This isn't even like, it's just stuff that I see in the community. You can be LGBT, I'm gonna give you an example. Actually, I'm gonna give you an example. I am an LGBTQ affirming therapist. I have extra training, I advocate, I promote equity, all the things. I'm a kink friendly therapist. Kink as in the community, the kink community, which is separate from the LGBTQ community. Put that out there. I'm kink friendly. I don't know all of the definitions and stuff. I gotta do a lot of extra research all the time. So if it's of no importance to why you're going to therapy, yeah, I can see you. You're being part of the kink community. Maybe it's just kind of marginal, incidental reason why you're there. You're just trying to navigate your relationships within the community. Sure, I can see you because I'm a kink-friendly therapist. But if that's your primary need, for you to come to therapy is like, I don't know my identity, I don't know my place within this community, those kinds of things, the relationships I have are overbearing or overwhelming or whatever it is. I'm not the best fit because I'm not affirming, I don't have all the extra training, I don't have all the extra knowledge. I'm gonna refer you to Matt Wood. That's the only guy we have here. Does that make sense, the difference? There is no shame when you come to see me because I'm kink friendly. But if you need extra stuff and that's the primary focus, I cannot say that I am kink affirming. I'm not a sexual health specialist, etc. Clear? Don't trust no marketing you see. I'm just saying. People get these things mixed up all the time. Understand where others stand. if you go, say you're in an integrated health setting, and there's 6 nurses that are on the weekend shift. Do you know if all the nurses are friendly? Or if some of them are gonna shame the client? I was gonna say student. Are they gonna shame the client? Are they gonna demean the client? Are all the doctors the best fit to see this client? Because sometimes they're not. But know who and where others stand. Also knowing the leaders and the community members. There are some people that I will not refer to. Straight up. Because I know that they're not even LGBTQ friendly, if not they're anti-LGBTQ. I don't see every queer person in the community. I'm one of the very few that has it rolled out on their page though, like, here's my sticker. Right, that doesn't mean I see everybody. Some people still have specializations. I don't treat eating disorders, for example. Because that needs medical care as well when it's super complicated. So I'm like, I know the 2 facilities in San Antonio. Because I don't feel comfortable making referrals to people if I don't know where they stand. Then you stand for nothing. So I need to know where you stand before I trust anybody, even if they're not my client. They reached out to me for help, I'm gonna give them a solid referral, even if I can't help them. That's outside of systems, that's inside of systems, especially in an integrative care setting where there's so much at stake for them sometimes, because that's where they're getting the medical and behavioral care. Who within that system can you trust and where do they stand? Yeah, I know that's hard. Because there's always, that not always, I'm not gonna say always, that's real overgeneralized. And you don't even have to be like real, like I'm gonna be, I mean, all my provision will be like, no, I'm not gonna refer to you. But within the system, you can see, oh, this one doctor, this one nurse always misgenders everybody. Just keep that information in your pocket. Just know, you don't have to be like, why are you always misgendering? You know, if you don't feel safe to do that. Ooh, that part was heavy. We ain't got time for all this. Samples of operations. What did I put on? I don't know what I wrote. Oh, this is what I do in my sessions. My missions and value statement. And how I integrate and how I collaborate with other partners is very clear on my website under my mission and values. It was on the mission and value statements when I worked at other locations. However, legislature has made some changes in how things are put. So that's also why I went private. There's pride flags everywhere in my office. I have a little bisexual flag in my office too. I'm wearing my pin today. You are safe with me. It's got a little progressive flag and the trans flag underneath it. I wear pride earrings all the time, all kinds of stuff. There's little things. The logo on my website also has everybody is safe here. It's meant intentionally for people of color and LGBTQ persons. Our social media is always going to uplift minority voices and marginalized voices. Side note, I have 2 different online social media presences. There's one for my business, Strengthening Wellness, and then there's Dr. Anna, who goes off on TikTok a lot because she has feelings. Those are 2 different things, and I still promote and uplift marginalized voices. Pronouns, we ask pronouns everywhere. Pronouns are on our name tags, on our doors, in our offices, in our emails, and in our documentation. I don't bill for insurance because personally, I want to make sure that I can use someone's pronouns, that I don't have to diagnose just to get paid for something and to potentially harm somebody going to, I got no problem diagnosing when I need to, and it's appropriate for further care, for higher levels of care, or to improve the trajectory or the course of their treatment. But if you come in because the world on fire and you think you have autism, why? So they can pull your autism chart? Quote. Know what I mean? So everybody in all documentation or offices is now they, them. When I'm writing, client Lena, they report that they are having issues. Client Anna, they also have issues. Everybody said it's grammatically correct. because I'm writing in third person. Writer and client collaborated to identify their needs. Writer and client collaborated to create a safety plan to meet their needs. Like, it's grammar, everybody's they, them. There. So, just support everybody. And I have a lot of individuals who just, they don't know their identity. I don't know. Today I'm queen, today I'm king. Cool, makes sense. These are also two books that I really, really enjoy. The Queer and Transgender Resilience Workbook, and then the Clinician's Guide to Gender Affirming Care. This one is more like self-helpy, but it's better with clinician directed. Just like her anti-racist workbook. You can do it on your own, and it's really helpful to do with a clinician. Because some of them are kind of heavy. And this is a clinical guide, so there's a lot of stuff on there about different kinds of modalities and treatment, and I didn't have time to condense a whole book into a training, but this is a great start. Also low-key fan, because that's Dr. Singh. Love her piece of that. What time is it? Good timing. Okay, I thought I was going faster than usual. So we have time for questions and comments. And you know what? This is the version where I didn't put the resources on the bottom. But I have a whole list. Questions, comments, concerns?
How would you approach a scenario in which, like, in an integrated setting, say a hospital or some type of medical clinic, that there's a patient who does have like a name and a specific pronoun that they like to use, they've communicated it, so they're open, but that staff is not actively using it. So when you go to do like advocacy, even if it's a small or big A, they go, no, don't worry about it. It's really not that big of a deal. Like, but you can kind of tell. So I just don't know how to like really approach that situation.
You said a big deal. The client says it's not a big deal, or the staff says it's not a big deal?
I guess either or. Like, I think if it's like the client, like, hey, what can I do to like advocate for this situation? Like, I wouldn't even worry about it. Like, I don't even want to make it a thing. I just want to get in, get out, like get treated. Let's go. And then like medical staff are not seeing the weight of it. So I just guys, like, how would you approach that situation?
Sure, I follow their lead. I'm always gonna follow my client's lead.
Yeah.
Yeah, I mean, for some people, it really isn't as big of a deal. You know what? I'm gonna tell you a story time. Story time. We have clients who just don't care. And my pronouns are they, them, but I don't know, I have a beard, so he, him doesn't hurt my feelings. Word, okay. And I think in certain cases, that initial dismissal could be them testing you out, or it could be in a hospital setting. My leg is broken, I don't care. Let me get my treatment, get in and out. In an individual one-on-one setting, if and when that keeps coming up, I'm going to request to explore it more. I also have that same exact issue with persons like, when I worked with a lot of students in the past, using their Americanized name. You can call me Annie. You can call me Bobby. And I'm like, no, teach me how to say your name. If I can say charcuterie, I can say your name.
The hard one.
It did take me, I can't say statistics still, but statistics.
Or what's that one?
Which one?
Like link them with wish timer?
Oh, never mind.
The wishing timer, it's like a sauce.
Worcestershire.
That,
Worcester.
okay, parking lot, hold on. Parking lot, cause I got a whole level of those guys. So it may not be important in the moment. And if that is, and it's short-term or immediate, like kind of crisis therapy or those kinds of things, I follow my client's lead. If it's the staff, if it's ER staff and client's not fussing about it, and they're triaging 50 people, I'm not gonna stop them from suturing something to be like, education time.
Stop that surgery.
Stop that triage assessment.
Take the scalpel off.
You need to learn. Anna goes by she, her. You know, so it's when you can and as you can. Daily exposure on a floor with staff, you can push back. Again, if the client is okay with it. Some clients may feel comfortable to only opening up to you and not to the other staff, and that's okay too. Follow my client's lead as the answer. This is the short answer that we gave you a long answer for. Follow up, or is that good? ¿Qué más? What else?
I think we work with JJC with a lot of kids.
Mhm.
A lot of the language that we is not always, socially aware and culturally sensitive, and it's a lot of like, you're not even telling me what to say. So I haven't really been ever confrontational about the language
Mhm.
yet. I would just wonder how to confront that. If maybe, I noticed at least if there's people around them that probably would be offended by that, they're just not saying anything. Cause they're like, well, I'm in juvie, I'm gonna tell this guy to respect me, I'm already in juvie, so there's like some level of like, maybe we should work on the language, and then another level of like, well, I don't know that I'm able to change how somebody speaks.
That's kind of the vibe of the question from back here, where it's follow the individual's lead. So if you had a kiddo who does use different pronouns or who felt comfortable doing that, you can use kind of your position of power in the icky way that there is power to advocate. Cause there's a lot of weird power dynamics within juvie. But like, yo, Anna said it's Anna, it's not Bobby. You talk about respect all the time, boo. This is what we're talking about. Okay? Now we're gonna do group or not, because you don't have to go to group, you can go to whatever it is, I don't remember all the punishments and the cell time or whatever. You don't have to go to group. You're talking big mad about respect, this is what we talking about. And that's just the way I talk to kids. I don't.
Cause it'll be little things too, like I have to do that biopsychosocial in the beginning, and I have to ask sexual orientation and pronouns, and I've gotten already like maybe twice. Why would you ask me that? Don't you see me? And I'm like, yeah, I have to ask them. And we just move on.
My language that I use when they're like, what do you mean? I'm a dude. Sure, thank you for answering. This question is
So
for
he,
everybody.
him then.
Huh?
So he, him then, like. just
So, okay,
confirm.
so he, him. These are questions that we ask everybody.
Yeah.
They may or may not apply to you, but it's for the people who might need it. This is why it's here. And I usually do that at the beginning of a biopsychosocial anyway. I say, I'm gonna ask you a whole bunch of really weird questions they may feel to you. Some of them are gonna feel intrusive. And some of them may not apply to you. Feel free to say yes, no, pass on as you want, but remember, it's for everybody. And then we start my biopsychosocial, and then if I still get like what do you mean, trauma?
Yeah.
Well, we can just get a yes or no in this section for now. We can circle back around if we ever need to. We don't need a trauma dump. Yes, no categories. Okay, are there any of those that you feel like I missed or whatever? So I preface always with, some of this is gonna be real random. What else? Does anybody need to come get a snack before they ask me a question? I know this is such a long morning and y'all heard me yap for 2 hours and change. Restorative breath. I'm all tired, one more. I introduce restorative breathing with a lot of my clients and a lot of my staff and students in general, because think of a marathon racer, like a runner, they're breathing literally the whole time. There's even patterns in how they change up their breathing when they're long distance runners. Sometimes being a student and having lots of different roles and being advocates, whether you're a big A advocate or little A advocate, or you're trying to learn how to all the blah, 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 and y'all all have people and identities outside of this space. So it can feel like we're drowning. So restorative breath is not like a marathon runner where there's like intentionality and planning. It's more like a marathon swimmer where you're finding those right times to pause before you change lanes or before you flip over or do those things of like, when do I take a breath? And then I gotta get back to it. Because if you stop, you're gonna drown. And a lot of people don't sugarcoat things. So a restorative breath is more like a marathon swimmer, because we don't all have time to sit and do mindfulness and activities and things like that. So sometimes it's just the and there's science and stuff behind it too, like the oxygen rates to your brain and all of the things. So if you need restorative breathing, every time you go potty, you go tinkle. Depending on how I feel for that day, if I have a lot of anxiety, because I'm dealing with a lot of stress and a lot of traumas, then I will do like literally like 5 squats just in the bathroom, just to get some blood flowing, because I'm feeling too agitated and I gotta do some things. Or if it's real heavy and sad. Because personally, as a senora, I'm gonna go to the ladies' room between every client. And that's an excuse when I don't need to, and I need to regroup. I either do my squats, my little 5 squats, or I do my restorative breath. Okay, go. And so hearing some of this information for some people can be heavy, and it's a lot. And it's an intro 101 kind of overview. Because I don't know everybody's orientation and stuff. Dr. Rob.
I forgot to ask earlier.
Yeah.
Could you talk more about the 2 spirits? You mentioned that
Oh, yeah.
being something that I think is common to like indigenous populations, but like I guess I'm wondering if overall, like what do you what else can you share about it?
Sure. So I am not the expert on two-spirit orientation, and soapboxy a little bit. So being, quote, transgender, or feeling like not in the body that one is born into, has a long cultural history across a wide variety of cultures and countries. I just touched on the US. There's so many different cultures and countries where being transgender or being of more than one spirit or identity is seen as a blessing. It's a good thing. So there's a lot of indigenous communities in North America and into South America where it's good. Like you were considered a wise person, or you were, one of the leaders because you had the knowledge of both genders and both spiritual identities and that kind of thing. So in the North America realm, mostly I think Canadian indigenous communities, they call themselves first people, really reclaimed two-spirit, because there's no one language within indigenous populations, because they were all stolen. They were all tortured or killed or erased. So there's no one, because there's still language, of course, from indigenous communities, but there's no one like, everybody that's indigenous speaks Nuatol, or I actually said that wrong, or, whatever it is. There's too vast and too broad, but being of two-spirit is that piece, the identity, and reclaiming that back.
Thank you.
I wish I knew more. I barely even know enough of my own indigenous roots. Because that's also complicated.
I think just as a whole, between that is like the two-spirit is not that you're in one gender and you think that you're not conforming appropriately or want to be in this other gender, or you belong in this other gender. It's a mixture of the both with the third gender.
Yes.
Yeah, so it's spiritually, you hold a feminine and a masculine spirit,
Okay.
and it holds a significance within the tribe spiritually. So kind of like almost like a shaman would be.
Oh,
They also are under the shaman. It's a very important figure. So they expect that there may be 1 or 2 in their community that have the masculine and feminine spirit, and they work together. Like the rituals, I'm not as versed in, but that's like the difference. It's like I look in the mirror and I am these two. I am one. It's a third gender.
okay. So there's a lot of spiritual significance
Yeah.
in a ritual and community-based context, I guess. Okay.
Thank you for clarifying. I always forget that it can also be it most primarily is third gender. I am neither or, but both and.
Yeah. And there was like a lot of, and you're right, it's a borrowed term from like, indigenous tribes from Canada. But the reason why is because the labels that we use and like Western culture don't necessarily align. So being like, homosexual or lesbian are not the exact same in those tribes. And because they have the third gender, there was a huge movement to then make their own names who are predominantly used now. And two gender is just a very, very popular version of it. Just because it holds so much significance. There's a lot of research out there about it.
Thank you, Jess, that's really helpful.
Thank you. It's a whole beautiful and understanding, and I need to know more.
Yeah.
Yeah. Very nuanced too. What else? Thank you for clarifying and helping, because I've lost. What else? Wait. Feedback.
Yeah.
I thought you had really nice slides.
I think there's not that many questions because it was very like well-rounded and expansive, and there was a lot of new information and then clarification on older information that we've learned throughout our program that hasn't had much light shine on it. So I think that's kind of why there's such like a weird silence, is because you've covered it really well. It was a great presentation.
It was thorough, very
Yeah,
thorough.
that was the word.
You.
You're welcome. 12:24. Oh, good, that's right. Oh, I forgot, I'm a client.
Yeah.
Yeah,
The worst is getting there and having to jump straight into it. So now you have like a second to like
that's
take a
why,
short breath. Yeah, right when you get in the parking lot.
well, that's also why I listen to, old rap when I drive. It clears my head.
And you say bold.
So what?
Like, what?
Like,
elderly people rapping?
wait,
Like, what year?
like
Talking about,
hip hop.
okay.
Okay, like when I'm feeling real salty, it's like NWA.
Oh,
Like,
okay. I
when I'm feeling
You're gonna
funky,
crash out?
it's like Run DMC.
I got
When I'm
you.
feeling kind
I
of
got you.
funky. No, I'm aging myself real bad.
Oh, I'm here with you.
Oh, okay.
Cause, I mean, I'm not that.
Sometimes my students walk in and they're like, what are you listening to? I was like, I don't know.
I'm not up there, but I know that, you know. That's what I was like.
I'm very definitely Gen X.
Yeah.
Very definitely. Y'all wanna take a picture of that? If y'all need to. Am I supposed to send these to you? I supposed, the slides, am I supposed to?
I'll put it, looks like,
Okay, let me,
and share it with the
Oh, let's see. There's one agent here that I wanted.
all right. I'll wait for y'all to do the thing. You know, what, how
I'll
about,
also send this
kept it on.
PowerPoint to y'all via email.
Yeah, that's fine.
I'm sorry I didn't label all my references on this page, but all the articles are there. My TikTok's not on there?
Just be careful of the account, not like that.
That's not even what I wanna
It's
say.
not gonna be the same for you.
What is my handle?
Cause we each were.
Does anybody follow me? That's creepy. No? I was at some pizza
Yeah,
place,
they filled it out when we.
and somebody was like, oh my god, and I'm like,
Written in by them.
But basically,
I'm just wondering, and then.
I also have two TikToks, one's where it's just cats. Where I just watch cat videos.
Because I'm on YouTube too. Like one day.
That's my hair.
Because under the presumption that this gets renewed, we'll be on one of these. Yeah. And if not, then paper. Goes in the bin anyways.
Sure.
Oh, it goes in the filing.
You're good.
Thank you.
Just need to write out the dates.
I was like, I don't know if I have my whiteout with me, but,
Yeah, double check with her.
I was like, I might.
Is this the same purple?
Since we went to.
That's my
doctor's, like,
TikTok.
That's the same purple.
Yes, that's.
Dr.
that,
Anna.
I wanna say.
It's so
I
complicated.
can't remember the only person.
Yeah, I
I
can't
know
remember which number is
that-
different for everyone, which one.
I only have it for this and dumb cat pictures.
The vendor number 0.
Yeah.
Did we ever?
I don't have
deny
TikTok
we need
either.
to change something?
Okay.
I only have social media because I own a business.
I didn't have Facebook
Okay.
until 2020.
Okay, the one with the 5 zeros is all.
Wow.
Yeah,
That's way.
and I
Alright.
used it
So we should take
specifically
one screen
for.
picture.
Yours.
Sandy, want to take a picture and be okay with it?
I'll be on picture with you.
Dr. I.
Project end date is 31st.
If we could probably put on June
Sorry.
30th now for this summer, because I completely it all ended. If they didn't, it's fine.
Okay, no, that, we left that blank. So
Okay.
you can just do
Sure.
from first to June.
Oh, wait, we stopped, Marion, stop recording. What am I doing?
Oh, girl.
How do I do this?
I'll put the matter like in.
Yours would be June 1st to June 30th.
Oh, it's not.
I'm talking to you, Jessica. Okay.